As a keynote speech and address the speakers. Thank you.
Good morning, everyone. We welcome you all from the Department of Psychiatry, Pinnamaneni at the Institute of Medical Sciences for the zonal CME. Dr. Ranjit sir, thank you for coming, accepting our invitation immediately. Madam Lakshmi Sarai, Madam our observer. Good morning, all the postgraduates and the faculty here. I hope we are thinking of and Dr. Sharad sir. Today the topic chosen is recent advances. I think in the management of various psychiatric disorders. So I hope you will gain some knowledge by the end of this day. And we have a QR code for the pre-test. Rajkiran sir has kept it outside. If anybody hasn't scanned, before his talk, we'll again put it on, display it on the PowerPoint here. Please do the pre-test, and then later on there is also posters which will be displayed for Rajkiran sir's topic. Okay, I welcome you all and have a nice day today. We are having lunch also is provided here, as you all know. So I think post-lunch session also, I expect most of you to come back. I just hope the other postgraduates will be joining in shortly.
First presentation is by Dr. Ranjit Kumar, Professor and HOD from the Department of Ashram Medical College. His topic is latest guidelines for the management of bipolar disorder. Sir, we welcome you.
Good morning, everyone. Welcome everyone first. I'm Dr. P. Ranjit Kumar. I'm Professor and HOD of Ashram Medical College. Today I'll be speaking on the topic latest guidelines for management of bipolar disorder. This is quite a lengthy presentation. So whenever the time is up, just tell me. I'll close it. And this topic, I think it's very important, especially for the exam going students. Most of the questions which will be asked in your long case or short case or viva, you will be able to answer, but if you concentrate well. So please concentrate. So I have taken my presentation mostly from Indian IPS or CPG guidelines, a few from CanMed guidelines, that is the Canadian and ISPD guidelines, and a few from NICE guidelines. But it's mostly because most of the examiners prefer this IPS guidelines. I have concentrated on that. And IPS guidelines, the clinical practice guidelines. Now we are having the third guidelines. The first one was in 2017. It was exclusively for adults. 2019 was exclusively for children. And the latest guidelines, which is 2025 and published in 2026, that is for adults again. And these are the latest guidelines. And coming to the topic, the National Mental Health Survey 2016, it says that the weighted current prevalence of bipolar disorder is 0.3%. and the lifetime prevalence of 0.5% with moderate to severe disability. Here you have to understand that with moderate to severe disability, you say it's 0.5%, but it may be more than that. And there are many other surveys like the World Health Organization survey, which says the prevalence is nearly 2 to 3% for bipolar spectrum disorders. So maybe but this one is from the National Mental Health Survey, which is pertaining to our country. So you should be able to quote this if they ask you in the exam, and maybe we are having a lesser prevalence here because of underreporting. And as we all know, bipolar disorder typically presents in late adolescence or early adulthood. First, when we suspect a patient to be suffering from bipolar, what are the assessments we need to do? We need to take the social demographics, age, gender, employment status, marital status, and onset. All of these have importance, which we'll understand later in the prognostication or in the management purpose or in the evaluation purpose. And so we have to take all of this and not forget anyone. Onset. Age at onset, the polarity at onset, is it manic pole, is it depressive pole, is it mixed? Acuity of onset, is it acute or subacute or insidious? Because acute onset, sometimes mostly you will be suspecting secondary secondary mania like maybe due to substance abuse. Peripartum onset. Peripartum is a period which the patient is very vulnerable to suffer from bipolar disorder. Any life events which precipitate the onset of bipolar in the course. In the course, we need to take the number of episodes the patient has suffered all these years, the predominant polarity, whether he suffered from predominantly manic episodes or predominantly depressive episodes, the inter-episodic symptoms and recovery, and how was he during the inter-episodic phase. Were there any residual symptoms or was it completely normal? And the pattern, was it manic depressive or is it depressive manic? Everything has a point in the management purpose and the prognostication. And is there rapid cycling or ultra rapid cycling? And did he have frequent hospitalizations? And the current episode, what is the severity? Is it mild, moderate, severe? What are the predominant symptom dimensions? The presence or absence of psychotic features? How does it compare with the past episodes? And in the precipitating factors, biological rhythm disruption. If we notice that most of the episodes are triggered by some sleep disturbances, or the onset is predated by some sleep disturbances. So biological rhythm disruption is very important. Medication non-compliance, that could be the reason for the onset. Is it due to substance use or peripartum onset? Like I was telling, it's a very vulnerable phase. And any psychosocial stresses which may be acute or long-standing, that is chronic. And the comorbidities, he must be suffering. Bipolar has a lot of comorbidities like anxiety disorders, obsessive compulsive disorders, we will see later, and also physical illnesses comorbidity, especially metabolic syndrome, because of use of the second generation antipsychotics these days in more number, there is a lot of comorbidity with metabolic syndrome in bipolar. And treatment history. What was the type of medication you took? Did you take first generation antipsychotic, second generation, or mood stabilizer? What was the dose he had taken? Or what was the length of, what was the duration of medication he had taken? What was the response to that particular medication he had taken? Because once he had a good response with one medication, we are more likely to restart the same medication. And the past and adherence, was he adherent or not? Reasons, and if he was not adherent, what are the reasons for discrimination? Why did he stop it? Any psychological interventions he had taken, ECT history, other treatments like neuromodulation, RTMS or any other neuromodulation techniques he had taken, whether he had used ketamine, and family history of mood disorders, family history of suicide attempts, family history of substance use, and in the psychosocial factors, especially among the caregivers, is there a perceived stigma among the caregivers, the expressed emotion among the family members, and the social support the patient has. So all this will be, you should remember all this while you're taking your case when you suspect a patient to be suffering from bipolar. And once you have confirmed that the patient is suffering from bipolar, how do you proceed with the assessment? Current episode assessment I told you prior. Use of rating scales. Rating scales like if it is a manic pole, young mania rating scale. If it is a depressive pole, Hamilton depression rating scale. And there is also the patient health questionnaire 9, which is a self-reported questionnaire for depression. And symptom monitoring. Severe mood changes can be easily identified, but when the mood changes are more subtle or mild or uncertain presentations, they may be missed. So for that, we need to monitor the mood every day. And long-term course assessment, there is this National Institute for Mental Health Life Chart method. In this National Institute for Mental Health Life Chart method, you can track all the illness phases and response to medication in each phase. And suicide risk assessment. This is the most important thing for every patient with confirmed bipolar. You have to assess for suicidal risk, and when are the suicidal attempts more, or when is the risk for a suicidal attempt more. Female gender, females attempt more, males complete it more. Early age at onset is associated with higher suicidal attempts. Predominant depressive polarity, obviously. Greater number of episodes, more likely to attempt suicide. Longer the duration of episode, more likely to attempt suicide. Persistent residual symptom in between the episodes, more likely to attempt. The presence of rapid cycling episodes, more likely to attempt. Previous suicide attempts or history of suicide attempts is more likely to attempt again. Family history of suicide is another risk factor, and comorbid substance use. So all these will be the risk factors for another suicide attempt. And like I told you, we also should do the caregiver assessment, like what is the knowledge they have about the illness, what are their attitudes towards treatment, whether there is any burnout among the caregivers, the perceived stigma and emotional burden. And there are structured questionnaires for assessing caregiver burden. Remember these. That is the family burden interview scale for caregiver burden, and also burden assessment schedule. And you also need to do the physical and medical evaluation, like the basic investigations. And once the bipolar disorder, there is differential diagnosis they have to consider. Once you have diagnosed a patient to be suffering from bipolar disorder, the most important one will be major depressive disorder. I'll see it in the next. I'll tell it in the next slide. You also have to differentiate it from substance-induced mood disorder, but that's easy because you just check the chronology whether there was a history of substance use which predated the mood symptoms, secondary mania due to medical conditions, neurological conditions, substance use, and personality disorders. In personality disorders, it's mostly chronic irritability with occasional flare-ups, whereas in bipolar disorder, there are discrete episodes of mania or depression or fixed episodes with completely normal euthanic phase. And so, what are the differences between unipolar and bipolar depression? This is asked a lot of times in the examination. How will you differentiate between unipolar and bipolar depression? So, in unipolar depression compared to bipolar depression, the onset is a little later, in the third or fourth decade of life. Whereas in bipolar depression, it is the second or third. The presence of these vegetative symptoms, insomnia, reduced appetite, reduced weight, is more common in unipolar depression. Negative family history of bipolarity, positive family history of unipolarity, obviously no history of manic or hypomanic episodes, and longer duration of depressive episodes. The depressive episodes are longer in unipolar depression compared to bipolar. And in bipolar depression, the onset is younger, more frequent episodes. In bipolar disorder, the number of episodes is more. Psychomotor retardation is more classic here. The presence of psychotic symptoms is more in bipolar depression. The presence of catatonic symptoms is more in bipolar depression. Suicide attempts are more in bipolar depression. And family history of bipolarity, and also atypical depressive symptoms. Atypical depressive symptoms, I think you know that is hypersomnia, hyperphagia, leading paralysis of limbs, and interpersonal rejection sensitivity. All these are more common in bipolar depression. And switch, antidepressant induced manic symptoms. These are more common in bipolar depression. So these are the differentiating features between unipolar and bipolar. I'll give the PowerPoint only to take any pictures. So coming to bipolar disorder, treatment of acute mania, the goals of treatment for acute mania will be rapidly and safely alleviate the symptoms, minimize the risk of self-harm or suicide, and also restore the psychosocial functioning. These are from the CBC guidelines. The first line for the management of psychomotor agitation or excitement, the first line which we use quite commonly, intramuscular lorazepam, intramuscular haloperidol and phenagyl, and intramuscular olanzapine. Intramuscular olanzapine, I don't think we use that frequently. So this is the first line they have given for the management of psychomotor agitation. The second line will be sublingual esnapin, IM haloperidol with IM midazolam, and olanzapine orally, disintegrating tablets. And third line, haloperidol, quetiapine, respiratory, paroral. And the point I want you to remember is, recently sublingual dexmedetomidine has been approved for treatment of agitation associated with bipolar disorder 1 and 2. It's not yet available in India, I think, but this one has been approved recently. So in the management of acute mania, the first line monotherapies will be, remember these drugs. So when you have a long case of bipolar disorder and when you're presenting the case, when the examiner asks you which medication will you prefer, you can choose from this and you can say the evidence that I have taken from IPS or CPG guidelines. So for acute mania in bipolar disorder, the first line monotherapies will be lithium divalproate, risperidone, quetiapine, aripiprazole, esnapin, cariprazole. What I want you to remember is, mostly we have the habit of saying olanzapine, but olanzapine isn't there in the first line monotherapies. olanzapine is actually efficacious like any other mood stabilizer or second generation antipsychotic, but olanzapine isn't present in the first line monotherapy because of the metabolic risk. Because of the metabolic risk profile, we do not prefer olanzapine in the first line according to the CPG guidelines. And for excitement, like I told you, you can use some benzodiazepines. And after giving the first line monotherapy drug, according to these guidelines, you have to wait for at least 2 weeks to assess whether the patient has improved or not. Give him at least 2 weeks. And after the 2 weeks, if the patient has not improved, you switch. If you had been using lithium, maybe use divalproate. If you have been using risperidone and there is no response, use cariprazine. So switch will be the next step. So first line monotherapy, and if the switch also has not worked, you can also try combination therapy with maybe lithium with quetiapine, lithium with cariprazine. These combination medications can also be tried. And if the patient has not responded to either switch or combination therapy, the second line monotherapy CPG guidelines gives is olanzapine comes in second line because of its metabolic risk. Ziprasidone because its tendency to cause QT prolongation, that is also second line. Carbamazepine is in the second line, and you can either combine a second line agent with a first line agent, such as lithium with olanzapine. And he says you can also consider brief electroconvulsive therapy at this point. So once the first line hasn't worked and the second line you have tried this and it doesn't work, you can also try brief pulse ECG. And if the patient doesn't respond after 2 weeks even to this, the third line monotherapy or combination therapy, the CPG guidelines gives is chlorpromazine, clozapine, or combination of haloperidol with carbamazepine or oxcarbazepine. So you may not be able to remember everything I am telling you right now, but once you go back home and read it, you can register it better. So if the patient responds to any at any of these phases, then you directly go forward with the maintenance phase. So the first line therapy, second line therapy, and third line therapy. First line therapy was all lithium, risperidone, and esnapine, cariprazine. Second line was olanzapine and ziprasidone and carbamazepine. Third line will be chlorpromazine, haloperidol, and haloperidol combination with oxcarbazepine or carbamazepine. And for first line this is the CanMed guidelines, the Canadian guidelines. The only difference here between this and CPG guidelines is he has included paliperidone. Paliperidone has been included in monotherapy, and he also says, and another important point in Canadian guidelines or CanMed guidelines is he has given hierarchical ranking. So what he means by hierarchical ranking is if he has placed lithium here first, if he has placed lithium here, it means that lithium has the maximal evidence in these therapies. So first choice should be preferably lithium according to this hierarchical ranking. So lithium is the best according to him. So among the first line drugs, the only difference between this and that guideline is he has added paliperidone, and he also has given combination therapy where you can combine an antipsychotic with a mood stabilizer in the first line. In the second line therapy he has given same thing like olanzapine, carbamazepine, ziprasidone, everything is same, but he has added one combination with this lithium and divalproate, which was not seen in IPS guidelines. And third line, he has given carbamazepine with lithium and divalproate, again chlorpromazine, clozapine, similar to that. Or there we had combined haloperidol with oxcarbazepine or carbamazepine. Here he has combined haloperidol with lithium and divalproate. And RTMS has been included in Canadian guidelines, and also the tamoxifen therapies. And first line and second line is hierarchical ranking according to him, but the third line will be he has just given it in alphabetical order, no particular hierarchical ranking. And once you have decided to start him on a particular drug, for example, we have decided that we'll put the patient on lithium. So once we have decided that we'll keep him on lithium, what are the investigations we will start with? What are the investigations we will do before starting the patient on lithium, and how we will monitor? This is the question asked by many examiners. what are the tests you will give before starting lithium? How will you monitor it? So the baseline investigations required when you keep a patient on lithium will be the hemogram, electrolytes because hyponatremia can cause lithium toxicity. Lithium can cause hypercalcemia, so the electrolytes of sodium and calcium will be important. The renal function tests like urea and creatinine, thyroid function tests because we know that lithium causes hypothyroidism. ECG is important because lithium can cause conduction abnormalities. Urinary pregnancy test, especially the reproductive age group, and weight and BMI. This you will do in the baseline and again follow up in the 6 to 12 months. How will you monitor lithium? This is again very frequently asked. So how will you monitor lithium? The first level of lithium you will take after 5 days after initiation. 5 days after initiation or increasing the dose. So the first dose you are supposed to take is day 5 after initiation. The sample timing will be 12 hours or 11 to 13 hours after the last dose. We call it as trough sampling because when the lithium levels are the least, we take the sample then. So 11 to 13 hours post dose and maintenance will be every 3 months for the first year and every 6 months thereafter. And when a patient comes to you who is put on lithium, what are the side effects you look for? A patient on lithium, what are the side effects you should look for? We know this polyuria, polydipsia. Lithium mainly causes gastrointestinal and neurological adverse effects. So you look for gastrointestinal disturbances and neurological disturbances like tremor, dysarthria, ataxia. And some additional tests may be serum osmolarity, 24-hour urine monitoring, EGFR monitoring. And there are certain high-risk groups like the elderly, those with renal impairment, and those who are using concomitant drugs, for whom the monitoring should be more frequent. And if you have instead decided to starting on anticonvulsant mood stabilizer, what are the investigations you would like to do before starting them? That is the complete hemogram, then the liver function test. Liver function test because we know these mood stabilizers like valproate, carbamazepine are hepatotoxic. Renal function test, uterine pregnancy test is very important, especially if you are considering valproate. Weight, we know that most common side effect of valproate is weight gain. Fasting lipid profile and fasting glucose at the baseline and 6 months thereafter. And whenever a patient whom you have kept on valproate complains of abdominal pain and vomiting, you should immediately check for serum amylase and lipase. Why? Why would you check with amylase and lipase? Because it's propagated to cause serum pancreatitis. And like lithium monitoring, serum valproate monitoring is not routinely required, but certain indications like poor response or non-compliance, you may be requiring it. And monitoring is similar to lithium, 5 days after the first dose. And same thing, you take it early in the morning, trough concentrations, and also the target dose should be 50 to 125 micrograms per milliliter. And when we are giving ER formulations at once daily formulations, before giving the next dose, that is 24 hours after the dose, at the trough levels, we take the valproate when we are taking it for once daily preparations. But if we are taking it once daily preparations at the night time, it may be difficult to collect the sample at night. So what we do is, we shift the patient for 5 days to the morning and then take it in the morning. Serum ammonia may not be routinely required, but if the patient complains of nausea, vomiting, lethargy, altered consciousness, serum ammonia will be required because valproate is also known to cause hyperammonemia. And next for carbamazepine, same thing. How you take the sample is the same, and the target level should be 4 to 12 micrograms per milliliter. Remember this will be important. Lithium levels, valproate levels, carbamazepine levels, very routinely asked. And for carbamazepine, you have to take hemogram because we know that carbamazepine can cause bone marrow depression, pancytopenia. So hemogram will be very essential, and also liver function test fortnightly for the first 2 months. And when you are keeping a patient either on carbamazepine or oxcarbazepine, it's very important to monitor for skin rash because they are known to cause Stevens-Johnson syndrome or toxic epidermal necrolysis. and instead if you have decided to go with antipsychotic, the second generation antipsychotic, what are the investigations you will be required to take? So it will be the weight. So just remember this, all the investigations you will require to take at baseline, 12 weeks and annually. Anyway, weight and blood pressure we do it every visit. And the only thing you'll have to remember is fasting lipid profile. You'll also have to take it 8 weeks and also 4 weeks. 4 weeks only for 3 drugs he has given. The 3 drugs are quetiapine, clozapine and olanzapine. Quetiapine, clozapine, olanzapine. We know that they have high propensity to cause hyperlipidemia. So you also take that sample at 4 weeks and also 8 weeks. So the investigations, all the investigations will be, you have to check the weight or BMI, the waist circumference, blood pressure, fasting lipid profile, fasting glucose or HbA1c and ECG. Whenever you decide to keep him on second generation antipsychotic. And prolactin monitoring also may be required in certain cases. In what conditions will be required prolactin monitoring? In females, whenever they complain of amenorrhea or irregular menses, will be requiring this. And both men and women will be requiring it if they complain of sexual dysfunction, decreased libido and galactorrhea. Whenever there are these complaints, prolactin monitoring will also be indicated. And especially if they are using prolactin raising antipsychotics like risperidone. And doses, lithium 6, please remember this. This is for acute mania, lithium 600 to 1200 milligrams per day. 0.8 to 1 milliequivalents per liter. This is very commonly asked. What are the serum levels for acute mania? That will be 0.8 to 1 milliequivalents per liter. But if you are taking it for the elderly or those patients with comorbidities, a slightly lower level, that is 0.6 to 0.8 milliequivalents per liter. Divalproate, how do you start? You start with 250 milligrams BDR thrice daily, and you go to a dosing of 20 to 30 milligrams per kg. Levels we have already discussed. And lamotrigine, how will you dose lamotrigine? Lamotrigine, we start with 25 milligrams. Every 2 weeks you will increase by 25 milligrams. Once he reaches 100 milligrams, you increase by 50 milligrams every 2 weeks. So by the end of 8 weeks, we will reach the target dose of 200 milligrams. So lamotrigine to build its dose, it will take nearly 8 weeks. And why are we titrating this so slowly? Why are we going so slow with lamotrigine dosing? Excuse me. Because of the risk of Stevens-Johnson syndrome or toxic epidermal necrolysis, you titrate it very slowly. But if you are titrating with sodium alcohol, you have to titrate it much slower because they are enzyme inhibitors. Whereas if you are titrating with carbamazepine, you titrate it much faster because they are enzyme inducers. And carbamazepine, we start with 200 milligrams daily, that is in divided doses, titrate 15 to 20. Valproate was 20 to 30 milligrams per kg, carbamazepine will be 50 to 20 milligrams per kg, and the usual dose is 800 to 1000 micrograms, sorry, 800 to 1000 milligrams per day for carbamazepine. And these will be the doses for antipsychotics. You can just see it. Nothing to say here, but remember that antimanic doses will always be higher when they are in comparison to antidepressant doses. Okay, now treatment of specific presentations in mania. If it is psychotic mania, see, it again depends. If you are going with mania with psychotic symptoms which is congruent, you know the meaning of congruent, right? For example, you go with mania with delusions of grandiosity, that will be congruent. Or you are going with depression with delusions of nihilism, delusion of guilt, worthlessness, that will be congruent. But if you are going with mania with delusions of persecution, that may not be congruent. So when you are going for mania with congruent psychotic symptoms, keep him on a mood stabilizer, that will be enough. But if it is mania with incongruent psychotic symptoms, you will have to add to the mood stabilizer and antipsychotic too. And mania with seasonal pattern, there is no specific drug which has shown any special efficacy. And rapid cycling. Whenever a patient presents to you with rapid cycling disorder, first try to understand what has caused or what has triggered this rapid cycling? What could have been responsible for this rapid cycling? So what are the major contributory factors for rapid cycling? Antidepressant use. So stop the antidepressants. Stimulants like methylphenidate. Hypothyroidism is another cause for rapid cycling. These are again asked very frequently. Rapid cycling, reasons for rapid cycling. Substance use, some organic conditions like traumatic brain injury, epilepsy. So look for the contributory factors towards rapid cycling. And here what we traditionally learn is for rapid cycling, valproate is superior to lithium. That's what we traditionally learn, but what the latest guideline says is no agent has shown consistent superiority in rapid cycling. And what you just selected based on the efficacy and the safety profile. And what the guidelines want you to remember is do not discard lithium just because it is rapid cycling. If lithium has shown to be effective and safe for that patient, do not discard it just because it is rapid cycling disorder. So we do not discard lithium. It can help in managing rapid cycling. And these will be the nice guidelines for rapid cycling disorders. I think time won't permit me, so I'll just skip this nice guidelines. And pharmacological treatment for mixed episodes. We have seen for acute mania, now the treatment for mixed episodes. The first, whenever a patient, you know what is a mixed episode, right? For the first years, I'm again trying to tell you. Mixed episode is when there are both manic symptoms and depressive symptoms in the same episode. So when there are both manic symptoms and depressive symptoms in the same episode, the first thing you must do is if the patient is already on an antidepressant, please stop it. So the first step in treating a mixed episode will be stop the antidepressant, stop stimulants, and stop substance use. That will be the first time. And the monotherapy for mixed episode it will depend on whether the mixed episode is predominantly manic or mixed episode predominantly depressive. So mixed mania will be different, mixed depressive episode will be different. For mixed mania, we go with aripiprazole, esnapin, olanzapine, cariprazine, divalproex, ziprasidone. If you notice here carefully, lithium has not been indicated in mixed episodes. And for mixed depression, cariprazine, urasidone. So urasidone, and if you notice it properly, cariprazine is there almost in all the for mania, depression, mixed, children, everywhere, not children. So cariprazine and urasidone. So these newer antipsychotics are very useful in mixed depression. And same thing, if it hasn't responded after 2 weeks, you switch to another first-line monotherapy or combination therapy with first-line agents. And carbamazepine may be considered for second-line option. And ECT, if there is a suicidal risk or catonic symptoms. So the first-line options for mixed mania, mixed depression. For mixed mania is aripiprazole, esnapin, almost the same. You don't have lithium here. And for mixed depression, it is cariprazine, urasidone. If you can make a mnemonic to remember, it will be much easier. And the dosing for mixed episodes, divalproex, like I was telling you, first line, carbamazepine, second line, and lithium, not recommended in the maintenance phase. Recommended only in the maintenance phase, not recommended in the acute mixed phase. So divalproex first line, carbamazepine second line, lithium, only for the maintenance phase. Now depressive episodes. They have looked into manic episodes, mixed episodes, now depressive episodes. In depressive episodes, remember this, very important. First line monotherapy will be quetiapine. Quetiapine has got the maximum evidence for depressive phase. Urasidone we also saw in the mixed phase. Cariprazine, urasidone, cariprazine both. Olanzapine, fluoxetine combination, OFC. So these are the first line monotherapies for depressive phase. First line monotherapies. There, quetiapine, urasidone, cariprazine, and OFC. OFC is present here, but it is in the second. Second line monotherapy in CME guidelines. Lithium and see what happens is when you want to start lithium and lamivudine, lithium takes some time before the patient can respond. And lamotrigine, like I told you, it takes a lot of time to build up the dose. So it's very difficult to treat with lithium and lamotrigine during an acute phase of depression. So what he says is, you may use it with the long-term goal, or with the goal that you will use it during the maintenance phase. So first-line monotherapies, please remember this. And if the patient has not responded to first-line monotherapy, here or there the trial was for 2 weeks in a manic phase. Whereas in depressive phase, each drug you give a trial of 6 to 8 weeks. So there 2 weeks trial, but in this depressive phase you give a 6 to 8 week trial. So like I told you, first we give the monotherapy trial. Once the patient has not responded, we switch to another first-line monotherapy or combination therapy like lithium or chloracillone. ECT may be considered at this point. And if the patient hasn't responded to first-line therapy and switch or combination therapies, the second line will be, you can go with monotherapy with second-line agents. Divalproex comes under the second-line agent. Lumateperone. Actually, lumateperone, the guideline says very effective drug. But the evidence is right now inadequate because it's quite a newer drug. The evidence is inadequate. Maybe later on it will be shifted to the first, but right now it is in the second line for depressive phase. So divalproex, lumateperone, and adjunctive antidepressants like the SSRIs or bupropion. So if you want to keep the patient on SSRIs or bupropion in the second line, the most important thing you have to remember is always do it under the cover of a mood stabilizer. Don't treat bipolar depression with monotherapy of antidepressants because of the risk of switch. So whenever you are treating with monotherapy with antidepressants, always do it under the cover of a mood stabilizer. So SSRIs or bupropion is only adjuvant medication under the cover of a mood stabilizer in the second line monotherapy. And third line therapy. And the difference, this is the CANMAT guidelines. CANMAT guidelines also has given the same drugs for first line monotherapy, that is quetiapine, lithium, lamotrigine, cariprazine, duracillone, and in the and olanzapine fluoxetine combination, which was in the first line monotherapy for CPG guidelines. It is in the second line therapy in CANMAT guidelines. Rest all are the same, that is divalproex, SSRIs or bupropion as adjuvant, ECT, and lumateperone. And third line we have many drugs like ariprazole, armodafinil, esnapen, carbamazepine, etc. You can look at it later. RTMS is also here. Olanzapine is in the third line here, second line for manic phase. SNRIs, monoamine oxidase inhibitors, because of their propensity to cause switch, they are placed in the third line monotherapies. And like I was telling you, when you are using these drugs, use it at a lower dose. Quetiapine, we had used 400 to 800 milligrams for mania. It will be a little lower here, 300 to 600. And cariprazine in manic phase, we had used 3 to 12 milligrams. Here it will be at a lower end, that is 1.5 to 3 milligrams. And olanzapine fluoxetine combination, we know that we have fluoxetine 20 and olanzapine 5 or 10 in our routine preparations. Bipolar 2 disorder, in the management of hypomania, you can just follow the same guidelines you had used to manage mania. Not much differences, maybe lower doses. And management of depressive episodes in bipolar 2 depression, here we have quetiapine or OFC combination, like I was telling you, 68-week trials. And same thing we had followed over there, that lumateperone may be considered, but the Indian evidence is less. And lithium and lamotrigine may be considered in the maintenance phase. Same thing from there to here, not much difference. And second line monotherapy, over there uracillone and cariprazine was in the first line. Now here they have shifted it to the second line here in depression in bipolar disorder 2. And electroconvulsive, there is a suicidal risk. And according to Kanban guidelines, the only drug which has approval for acute depression bipolar 2 is quetiapine. There is no OFC here. And maintenance therapy will be quetiapine, lithium and lamivudine. And another thing you have to remember here is, here he has given another combination of lithium or lamivudine with sertraline or venlafaxine. In second line monotherapy for bipolar depression, he also has given a combination of lithium or lamivudine with sertraline or venlafaxine. One thing we should remember in bipolar depression 2 is the propensity to cause switch from depression to mania is much lower in bipolar depression 2 compared to bipolar depression 1. So we can use antidepressant monotherapy a little, maybe if it's required. Not, we don't need to be worried about switch like in the bipolar depression 1 to that intensity. So sertraline or venlafaxine is the second line here. And maintenance therapy. Once the patient has been stable on acute drugs, what is the maintenance therapy? And why does maintenance matter? Why should a patient be kept on maintenance therapy? Because annual relapse risk untreated, if you do not keep the patient on maintenance therapy, untreated episode, the risk of having a relapse is 23 to 40% for untreated, whereas on treatment it is 19 to 25%. So the risk nearly doubles if you haven't kept him on a maintenance agent. And the studies have also shown that if the patient is continued on lithium during the maintenance phase, then the risk of relapse is only 1/3 to that in which no maintenance therapy was there. And our Indian data says that nearly 80% of patients will relapse within the first 10 months if the patient is not placed on a maintenance therapy. So that is the importance of maintenance therapy. I want you to know the difference between continuation phase and maintenance phase. So once the acute phase has come down, the first 2 months we classically call it as the continuation phase. During the continuation phase, the goal is to prevent the recurrence of the same episode. Whereas in maintenance phase, you are preventing the recurrence of a new episode. After the 2 months, then we call it as maintenance phase. And to keep a patient on maintenance therapy, you will have what are the things you will consider whether to keep the patient on maintenance therapy or not. It will be the illness course, like the number of episodes he had, how severe were the episodes, did he have suicidal risk during the episode, were there psychotic symptoms during the episode, was it very severe. So all this will go into thinking or in understanding whether to keep the patient on maintenance therapy or not. The first line maintenance agents which the clinical with the CPG guidelines has given us are lithium, divalproex, quetiapine and lamivudine. NICE recommendations during maintenance phase. What does the NICE recommendations say? The NICE recommendations say whatever drug has been useful in treating the manic phase, continue during the maintenance phase. But it also says that leaching is the best. So what you can do is you can psychoeducate the patient. You can tell the patient either to continue with the drug which has been helpful during the acute phase, or you can tell him that lithium is the best drug during the maintenance phase, or I'll switch from the drug which has given the response prior during the maintenance phase. Now I'll switch it to lithium. That's what NICE guideline says. And it also says that if the lithium has been ineffective or partially effective, you add another mood stabilizer like divalproex during the maintenance phase. And if the patient has not been able to tolerate lithium during the maintenance phase, or if the patient is not able to tolerate lithium, instead of lithium, you have the option of going with olanzapine, quetiapine, or divalproex. How do you manage the common comorbidities? Just tell me whenever the time is up. I'll just close it. Okay. So bipolar disorder, the most common comorbidities will be anxiety, obsessive compulsive disorders, substance use disorders, and attention deficit hyperactivity disorders. These are the most common comorbidities with bipolar disorder. The main crux of bipolar with comorbidity is stabilize the mood first. Once you have stabilized the mood, then you can think of treating the other things. So stabilize the mood first. Always prefer mood stabilizer in combination with second generation antipsychotic, and avoid switch using medications in comorbid conditions. Let's see individually. If you have a comorbidity of bipolar disorder with anxiety, we can choose a drug which is useful both for the management of bipolar and anxiety. And one such drug we have in our armory is quetiapine. So quetiapine is a drug which is useful in the management of both bipolar disorder and also anxiety. So quetiapine will be a good choice in treating bipolar whenever it is comorbid with anxiety, and also adjuvant gabapentin. And if you are treating anxiety in bipolar with SSRIs, be very careful because of the risk of switch. Use it under cover of a mood stabilizer. OCD also same thing. OCDs we know that main drugs we use in OCD are SSRIs, but there is a risk of switch. So what he says is, the evidence says, as much as possible, try if the patient will respond to behavioral therapies, exposure response prevention or whatever. But if that's not enough, you want to put the patient on SSRI, please do it only under the cover of a mood stabilizer. And please don't use clomipramine. Clomipramine is a tricyclic antidepressant, so there is an increased risk of switch. So if there is comorbidity with bipolar disorder and OCD, please avoid clomipramine. And another important thing you must remember is second generation antipsychotics like olanzapine, clozapine, they also cause OC-like symptoms. Second gen drugs like olanzapine, clozapine, quetiapine, they are known to cause OC-like symptoms, so it's better to avoid it. You can instead augment with drugs like risperidone or aripiprazole. And substance use disorder, but in substance use disorder, you'll have to manage both disorders concomitantly or together, because most of the times the mood disorder episode may be due to the withdrawal effect of that particular drug. So you have to treat both the conditions concurrently. And he says that lithium and divalproate is much more superior to lithium in the use of substance use disorder. And also he says aripiprazole or olanzapine, not just in the use of bipolar disorder, it is also useful in reducing cravings for alcohol and cannabis. So there is evidence for aripiprazole and olanzapine for also reducing cravings for alcohol and cannabis. And when you are treating attention deficit hyperactivity disorder, the problem is when the main therapy or the main treatment we give is methylphenidate or the stimulants when we are treating ADHD, but there is a risk of switch when the patient is already having bipolar disorder. So what the guidelines say is ADHD, always keep the patient on therapies first, psychoeducation and behavioral therapies. That will be the main therapy, that will be the main thing. Control the mood first. So stabilize the mood first. Once the patient has been stabilized, once the patient is on maintenance, on euthymic, then you can consider putting the patient on methylphenidate during euthymic phase, and always under the cover of a mood stabilizer. And we know that bupropion is effective both for ADHD and also for depression. So bupropion adjuvant therapy with the mood stabilizer could help in treating both this ADHD and bipolar. Okay, thank you. I'll just send the PowerPoint, you can read it yourself. Okay, so I'll try to cover the most important slides I have. This will be covered for you anyway in neuromodulation techniques. Please just read the guidelines, it's quite simple. This is from Kahneman Guidelines, Management of Mania and Depression in Children and Geriatric Age Group. This is important. So, bipolar disorder management during the peripartum period and lactation. So, we know that, so when a we know that most of the pregnancies are not actually planned. So a patient with bipolar, always pre-conceptual counseling is very, very important. And discuss, and if the patient is not planning for a pregnancy, contraceptive counseling in bipolar disorder is very, very important. And whenever a patient with bipolar comes to you of the reproductive age group, inquire into the last menstrual period and also do a urine pregnancy test if it's required. And during this phase, optimize with folic acid. Folic acid during the first trimester is very important, and even prior to that, and also manage the comorbid conditions and risk-benefit discussion and share decision. So we have 3 possible options for a patient with bipolar and the patient is pregnant. There are 3 possible options. The first option will be monotherapy. Use a single drug, monopharmacy, and at its least effective dose. The second option will be discontinuation, giving a drug-free period and maintaining only on psychosocial therapies. And the third one will be substitution with reproductively safe agent. For example, if the patient is on valproate, instead of valproate, you can shift him to a safer drug. You can shift her to a safer drug like lithium or lamotrigine. And for a patient who is on lithium, there is a small, you all know that there is a small absolute risk for Epstein's anomaly for a woman on lithium. The risk is 1 in 1000 or 1 in 2000. So the risk is not really that much, but there is a risk which is 20 times higher than the general population. So always you have to consider the risk-benefit analysis every time. And if you have decided to keep the patient on lithium during pregnancy, at the 20 weeks, the fetal scan will be very, very essential. And the antipsychotics which have shown to be very effective during pregnancy and lactation are quetiapine and olanzapine. And aripiprazole, a warning has been given because aripiprazole is known to cause lactation failure. Okay, remember that. And regarding breastfeeding, we know that most of breastfeeding is always mostly is encouraged and it's always encouraged trough feeding. Trough feeding is just before taking the dose, you ask the mother to feed the infant. Another important thing will be telling the family members to take care of the baby during the sleep time, so that the mother has proper sleep, because we know that sleep disruptions are most common triggers for these episodes. And always remember that postpartum phase is a very vulnerable phase for a mother to have another episode. So educate the mother about the various warning signs for detecting relapse, and resume maintenance therapy promptly after childbirth, close observation, and remember one thing is valproic acid. Valproic acid has a high risk, 8 to 10% of congenital fetal anomalies. So the CPG guidelines says it's totally contraindicated in pregnancy. So valproate, contraindicated in pregnancy. Remember that, because of the risk of congenital malformations, most commonly the neural tube defects, the risk being 8 to 10%. And among the SSRIs, paroxetine also has a risk. So paroxetine, please avoid during pregnancies. And if you are keeping the patient on clozapine, you should also monitor. Clozapine is usually not advised, but if you have to keep the patient on clozapine, you should also monitor the infant's blood for ANC monitoring. Okay. So the take-home points will be: lithium remains central across all the phases. Newer SGS like urazolone, cariprazine, lumateperone, very useful and mixed features. Avoid antidepressant monotherapy, and always think in phases. Is it manic, depressive, or mixed? And is it acute or continuation or maintenance phase? Thank you.
Dr. T. Ram Naresh Reddy sir, Assistant Professor from Siddhartha Medical College, here to present the topic of recent advances in management of schizophrenia. We welcome you, sir.
Thank you for giving me this opportunity. My topic today is newer and emerging trends in the management of schizophrenia. Myself, Dr. Ram Naresh, Assistant Professor, Department of Psychiatry, Government SIMS&RF Medical College. So, the learning objectives today is, in the initial part, I will just brush up what is known until now about schizophrenia, and then what are the limitations of current treatment approaches. Then I will go into which areas of research, into which areas the research is going on, and what are the new agents that were developed, and also using how to use people are trying to use the technology in the treatment of schizophrenia. So first, I'll in the initial part, first 15 minutes or 20 minutes, I will tell what is known until now. So first things, burden of schizophrenia, about 24 million people worldwide are suffering, and lifetime prevalence is around 1% anywhere in the world. And there will be a decrease in lifespan of 15 to 30 years. 25 to 30 years, there will be decreased lifespan, mostly because of lack of self-care, cardiac and metabolic side effects. And 3 to 4 times that of general population, the mortality rate will be, and 5% people will have completed suicide. And the thing is here, there will be no functional recovery. Most patients, we are able to manage psychotic symptoms, but there is never going to pre-morbid levels. So there will be major caregiver burden, and it is one of the major cause of disability. So schizophrenia is a prototypal disorder. It is like five dimensions of symptoms are present, and first, as you already know, the psychotic symptoms, which include hallucinations and delusions, they consider this is the excess of normal functions. And then there are negative symptoms, that is 5As they call, anhedonia, abolition. These things, they are reduction of the normal symptoms. And then cognitive symptoms will be there, that is executive dysfunction. And then affective symptoms will be there. Like these people will have anxiety, these people will have depression, and there are risk of 5% completed suicide is also there. And then aggressive symptoms. So these people are more aggressive and agitated. So there will be violence, and the violence are of 3 types. But our psychotic violence, people who commit homicide in the presence of hallucinations or delusions, is only 5%. So then, what are the negative symptoms? There is the dysfunction of communication. These are all the reduction of the normal symptoms. Dysfunction of communication, the affect will be less, and there will be no drive to communicate socially, and there will be no pleasure, no interest in deriving any pleasure, and also asociality and evolution. There will be they don't have any drive to do any work. So these are some of the negative symptoms. And then cognitive symptoms. There will be the processing speed will be decreased, attention span and concentration will be decreased, verbal learning speed is decreased, and then visual learning is also decreased. There will be the social cognition will decrease, and the executive dysfunction, the capacity to reason and solve the problems is also decreased. And then classic dopamine hypothesis. So this you all know there are 4 classic dopamine pathways, and the first one is mesolimbic pathway. It extends from ventral tegment area to nucleus accumbens. And then the other is mesocortical pathway, which extends from ventral tegment area to dorsolateral prefrontal cortex and ventrolateral prefrontal cortex. Another 2 pathways, These are the nigrostriatal pathway extends from substantia nigra to striatum, and then fourth pathway is called tubulo-infundibular pathway. So what happens mostly in psychosis is there is increased production of dopamine in the mesolimbic pathway, and that is hyperdopaminergia in the mesolimbic pathway, and there is hypodopaminergia in the prefrontal cortex. So dorsolateral prefrontal cortex is mostly for cognition, and ventromedial prefrontal cortex is mostly for processing of emotions. So hypodopaminergia in the dorsolateral prefrontal cortex will cause cognitive symptoms, and hypodopaminergia in the ventromedial prefrontal cortex will cause affective symptoms. So the other two things, mostly what we do is we use dopamine antagonists. Since the dopamine is more in the mesolimbic pathway, which is causing positive symptoms, hallucinations and delusions, we give dopamine antagonists. So what will happen is, the nigrostriatal pathway, the striatum is helpful for movements. So when we are blocking that dopamine, people will get motor symptoms. And then this tubulo-infundibular pathway, when blocked, it will cause hyperprolactinemia. So this is the classical dopamine hypothesis. The other important hypothesis which you should know is glutamate hypothesis. So what they say is schizophrenia is both neurodevelopmental and neurodegenerative. So the neurodevelopmental thing is, some of the genes like DISC1, disbinding and uracil, these are helpful for normal production of glutamate. So when there is glutamate production, when when it is adequately taken up by NMDA receptors, it will cause long-term potentiation, and there will be strengthening of synapses. So if there is adequate NMDA receptors, NMDA function is very good, then the strengthened synapses will they will survive. Otherwise, if there is any fault of genes, or if there are any environmental stimuli in the growth phase, aberrant environments expressed emotions or cannabis, or any substance abuse in the early phase of life, what will happen is the NMDA receptors will be hypofunctional. When there is no adequate NMDA receptors, the glutamate cannot be taken up, and there will be no production of AMPA receptors, and the synapses will not get strengthened. So these synapses, they will be eliminated in the process called computative elimination. So weak synapses will result, and this is causing schizophrenia. So what is the only thing you have to get in mind is, glutamate is considered the master switch, and entire most of the neurotransmitters, everything is controlled by glutamate. So it's very important to look after glutamate in our treatment things. So these are some of the glutamate pathways. I want you to mostly remember these things: descending cortico-brainstem pathway and the hippocampal accumbens pathway. See, this is from prefrontal cortex, it will end up in ventral tegmental area, and here it will get connected to dopamine towards nucleus accumbens, mesolimbic pathway. This one pathway you have to remember, and then this hippocampal accumbens pathway from ventral hippocampus towards nucleus accumbens. This is one important pathway. And then these two, direct cortical, which means GABA interneurons, and indirect cortical. These are within the cortex. So you remember these four very important pathways. I will be coming to you. So here, in the presence of normal NMDAs, here in the GABA neurons, there will be a good amount of glutamate will be produced, and these GABA interneurons, the inhibition from these GABA interneurons on this descending cortical pathway will be normal. So there will be normal production of dopamine here. But what happens is here on the GABA interneurons, the NMDA receptors will be hypofunctional. So the amount of GABA inhibition on this pathway will be less. So there will be glutamate hyperactivity here. Since it is directly connected to dopaminergic neuron, there will be more production of dopamine here. That's how this is playing as a master switch. Process, that is deficiency here, is resulting in increased production of dopamine here. You are getting? So this is one pathway. The next second is, I told you, ventral hippocampal pathway. Here also same. In the presence of normal NMDA receptors, on the GABAergic interneuron, see here there will be normal production of GABA, and there will be normal inhibition. So excess glutamate overactivity will not be more here. So normal. Then here GABA interneuron, and from here there will be normal production of dopamine. But here what will happen is in NMDA hypofunction on the GABA interneuron, glutamate hyperactivity will be high here until nucleus accumulates. So since glutamate is more, from here to globus pallidus, there will be GABA interneuron. So less amount of GABA is produced. So this will cause increased excitation here. So here again dopamine will be more. You are getting? These are from Stephen's study. You go, it will be a little bit confusing, but once you are well versed with these structures and circuits, it will be easy. And then the similar mechanism, mesocortical pathway. So same here, GABA interneurons, the NMDA receptors will be hypofunctional on the GABA interneurons. So there will be dopamine excess, glutamate hyperactivity will be here more. So there is GABA interneuron here. This will cause less dopamine production in the DLPFC and ventromedial prefrontal cortex. This will result in cognitive and negative symptoms. So glutamate is a master switch, and it will indirectly act on the dopamine neurons to cause psychosis. So that is the basic crux you have to know. One more hypothesis is serotonin hypothesis. Serotonin also, see, there are about 12 serotonin receptors are there. Everything has its own action, but what is concerning us is the remaining receptors are implicated in depression. But what is concerned in terms of psychosis is 5-HT2A receptors. 5-HT2A receptors is always excitatory, but it depends whether it is on glutamate neuron, whether it is ending on glutamate neuron, or whether it is ending on the GABA neuron. That will decide. So here it is directly related to glutamate neuron. So since it is excitatory, it causes increased production of dopamine here. But here it is ending upon GABA interneuron. So it will cause decrease in the production of dopamine. You are understanding? On which, if serotonin circuit is ending on which neuron, it will decide. Whether it is ending on the glutamate neuron or whether it is ending on the GABA neuron will decide whether there will be increase in the production of dopamine or decrease in the production of dopamine. So here you see 5-HT receptors in the prefrontal cortex. They are ending up directly on the glutamate neuron. So over hyperactivity of 5-HT2A receptors will lead to increased production of dopamine and it will lead to hallucinations. But here in the prefrontal cortex, from the prefrontal cortex, it might end up in a glutamate neuron. But here there is in substantia nigra, this glutamate is ending upon GABA interneuron. So there will be low production of dopamine and it is resulting in dopamine-induced Parkinsonism. Okay? And this third is prefrontal cortex to prefrontal cortex. Here hyperactivity because of GABA interneuron, low dopamine in the prefrontal cortex, resulting in cognitive and negative symptoms. So some of these things, three interconnected pathways linked to hallucinations and delusions. One is dopamine hyperactivity at D2 receptors, NMDA receptor hypoactivity at GABA interneurons in the PFC, and serotonin hyperactivity at 5-HT2A receptors. This imbalance. So this is the crux. This is the basic. And then next I am going. So what has happened until now? With this knowledge, what has happened? Actually, in the first, in 1950s, there are so many psychiatric patients, so many people suffering with psychosis, like 1% everywhere in the world. But what they were doing is they were not having any agents to treat them. They were not knowing theory. So most of the patients were kept in asylums and they were not treated. They were left untreated. But for sleep, Chandler, scientist named Chandler, he used chlorpromazine for sedation. Instead of decreasing sedation, it has decreased psychosis. So it's an accidental discovery. Then from 1950s to 1970s, they have been looking at the possible mechanisms, how this chlorpromazine has acted and how it is decreasing, and they came up with this dopamine hypothesis. So what they were using is D2 receptor antagonists. Up to 1970s, 1980s, they were using this D2 receptor antagonists. So what happened is, when you are blocking dopamine receptors, like I already told, this nigrostriatal pathway will also be blocked, and there will be condition called neurolepsis, wherein people will be like less movements will be there, their emotions also will be down, affective flattening, like secondary symptoms, secondary negative symptoms they are called. So that condition was called neurolepsis. So this era of antipsychotics were called neuroleptic era, and they include D2 receptor alone antagonists. These are called the first generation and effective in treating positive symptoms. But what they are calling is secondary negative symptoms, hyperprolactinemia, and motor side effects. Drug-induced Parkinsonism, acute dystonia, akathisia, NMS. NMS is one of the emergency conditions in psychiatry, and then tardive dyskinesia. What we do when we get motor side effects? We give anticholinergics. Anticholinergics will work in 20 minutes. How will they work? They will cause competitively they will block the dopamine receptors, D2 receptors, and then they will decrease dopamine-induced Parkinsonism. So these were some of the early agents. They are completely D2 antagonists. And then next came the era of pines and cones. So what happened? They somehow accidentally discovered that these are also, some of these agents are blocking 5-HT2A receptors, and by using these 5-HT2A receptors along with D2 blockade, we have less amount of motor side effects. So why can't we use these things? So that includes the olanzapines, methylamines. They are D2 and 5-HT2A receptor antagonists. The pines, downs, and roll. They have less EPS, less negative symptoms, and less cognitive impairment. But what they have observed is they have metabolic effects, weight gain, dyslipidemia, QTC prolongation, cognitive modulation, and the risk of hypercholesterolemia is less, but still comparatively more. So these are 5-HT2A binding by pines, risperidols, and 2-FLIPs. These are aripiprazole. See, clozapine has high 5-HT2A binding here, more than others. That's why it causes less EPS. And then, so this impact of antipsychotics on cognition. And conventional antipsychotics cause additional neurocognitive impairment. So instead of benefiting these patients, we are causing cognitive impairment is observed. So atypical antipsychotics provide a little bit better relief than typical, which are D2 antagonists. So when we are giving anticholinergics and antihistaminics to combat the blockade of the side effects which are coming from first generation and second generation antipsychotics, we are doing with anticholinergics and antihistaminics. But thing is, there is also this term called anticholinergic burden. They will cause cognitive decline and memory problems. Another is quetiapine. Quetiapine, it has more antihistaminic properties, and there will be cognitive impairment within 6 months. So then there are need. So what we have understood until now, they are effective at treating psychosis, but they are causing cognitive impairment and a lot of metabolic side effects. So then this another mechanism has come. See here, this full agonist, D2 agonist, full agonist, they will produce lot of dopamine and they cause psychosis. And the antagonist on the middle end of the spectrum, by blocking these things, we are decreasing psychosis. So somewhere around here, D2 agonism, partial agonism here towards will not decrease psychosis. They will decrease psychotic symptoms in Parkinson's disease. But here towards this end, if we are using antipsychotics, D2 partial agonists, they will decrease psychosis. And here these are 5-HT2A antagonists and inverse agonists. You are understanding how they will do is they will block the D2 receptors, but they will not allow these D2 receptors to express fully. Partially only they will allow to express. That's how they will decrease the amount of dopamine release. Then comes the ripiprazole, and here we have aripiprazole. These are D2 5-HT1A partial agonists. They are aripiprazole and brexpiprazole and phenylalanine roluperidine. These are inverse agonists and selective antagonists. And they have no metabolic side effects and no hyperprolactinemia. But what they cause is akathisia. And they have limited efficacy. We can stick to here only, but thing is they are not as effective in decreasing psychosis symptoms like D2 antagonists and 5-HT2A antagonists. So they have limited efficacy and they have less sedation. So now there is a treatment gap. So these are the unmet burden. So we have D2 antagonists, D2 plus 5-HT2A antagonists, and D2 and 5-HT1A partial agonists. Until now we have this, but still there is 50 to 80% of relapse, 20 to 30% treatment resistance, 50 to 60% people will have negative symptoms, 75 to 85 cognitive impairment, and only 20 to 30% is functional recovery. So now the treatment yes, we can decrease psychotic symptoms, positive psychotic symptoms we can decrease. But now the treatment is shifting towards negative and cognitive symptoms, and in the middle of this we have this treatment resistance, and our another goal is functional recovery of these patients. So from now the exact topic, like which areas the recent advances are happening in treatment of schizophrenia, treatment resistance strategies, novel mechanisms, long-acting injectables, the treatment of negative and cognitive symptoms, and digital psychiatry treatments. So first things, see, I told schizophrenia is neurodevelopmental in that abnormal genes and aberrant environmental lead to hypofunction of NMDA receptors, and there will be loss of neurons. Synaptic, good synapses, strengthened synapses will not be there, weak synapses will come, and that is causing schizophrenia. But this process will happen after getting schizophrenia also. Like if you are not treating these psychotic symptoms, the hypofunction of these glutamate receptors will be happening, and there will be progressive brain tissue loss after first episode, second episode, third episode. So if there are more number of relapses and large duration of untreated psychosis, it will result in treatment resistance. This is one mechanism of treatment resistance. There will be loss of synapses. So early intervention is one of the things, and if you have to reduce the duration of untreated psychosis. Shorter duration of untreated psychosis, better outcomes and better recovery. And then treatment resistant schizophrenia, I'll say the facts first. So failure of two antipsychotics, 40 to 60% only respond to first line antipsychotics, and there is greater cognitive impairment and negative symptoms and more hospitalization and disability. So even when we are treating with like we are first episode psychosis will come, we will give antipsychotics. But what will happen is over a period of time, these people will stop responding to the same dose of antipsychotic or the same antipsychotic itself. What's happening is supersensitivity. Once that dopamine neuron is come into contact with these antipsychotics, there will be upregulation of this overreactivity, this like hyperimmune reaction which we get. This will happen, and that is one hypothesis that treatment resistance happens because of dopamine supersensitivity. That is one mechanism, and they have observed that like only 50 to 60% people are responding to antipsychotics. Why the remaining 40% are not responding is in these 40%, what is happening is they are not having hyperdopaminergia as I stated in the mesolimbic pathway and mesostriatal pathway, or there is like less dopamine is observed in these things, in these people, and normal dopamine level is normal, which means this dopamine hypothesis is correct only up to 60%. The remaining 40% we are not knowing what's happening. That's why this treatment resistance is emerging. So we need to get understanding more, like remaining 40%, that's what we are trying to achieve, what's happening in the remaining 40%. So this is dopamine supersensitivity hypothesis. There will be need for increasing doses, rapid release during withdrawal, and tolerance, like alcohol addiction. There will be addiction of antipsychotics. So this is happening. And then dopaminergic subtypes, I told hyperdopaminergic subtype and hypo and normal dopaminergic subtype. The third is glutamate hypothesis. Like what I told, there will be less hypofunctional NMDA receptors in the prefrontal cortex. But some people have shown increased glutamate levels in the anterior cortex of patients with DRS. So this is one mechanism which we didn't get the understanding of why it's happening. And then oxidative stress and inflammation. This can be one reason. So lipid peroxidation is a measure of oxidative stress. It is elevated in patients with TRS, and gene deletions in glutathione acetylcholine. These people also show TRS. So the remaining 40%, one mechanism might be normal dopaminergic people. One mechanism may be increased levels of glutamate in these people, and oxidative stress and inflammation can be one cause. And another serotonin hypothesis, 5-HT2A levels, as I told, they are increased. There is hyperactivation in the prefrontal cortex, but here these people have lower levels of 5-HT2A, and there are a lot of polymorphisms in 5-HT receptors and serotonin uptake serotonin transporters are also there are a lot of variations. And then as usual genetic variants are also there. So how we have to look at it is we have to take the clinical history of the patient and we have to see like his genetics, and then fine tune which antipsychotic will suit this person, whether he will go into TRS or not. And if he is going into TRS, he will fall in which category, like glutamate category, oxidative inflammation, oxidative stress. That's how we have to fine tune. And I think that will happen in next 10 years. So clozapine. So until now, up to now, the gold standard for treatment resistance is clozapine. So why clozapine? These are the outside clinical effects. It has reduced risk of suicide and it improves aggression. So this and all you can get like how you will start, how you will titrate, how you will monitor the target level of 350 to 600. Beyond this, the seizures will happen and there will be myocarditis. How you will check these things you have to see. And there are augment like amisulpride. Some agents are helpful in along with clozapine in treating. But the thing is, why clozapine? Why clozapine is treating some patients who are having TRS. So because clozapine is observed to have some actions on glutamate. Glutamine, it's a precursor of glutamate. It is increased in putamen of patients with clozapine responsive TRS. People who are responsive to clozapine, they have increased glutamine levels in the putamen. So it is showing, clozapine is showing us the way that yes, I have some mechanisms which can act on glutamate, and so I am more available for treatment for these TRS patients. So it has high affinity for DR4 receptors and it causes upregulation of AMPA receptors. And clozapine also increases levels of L-glutamate and D-serine. These are co-transmitters. Without these co-transmitters, NMDA receptors will not function. You go, like everything I cannot tell, but for the action of NMDA receptors, for long-term potentiation to happen, calcium channels should open. So for NMDA receptors to act, it requires these things, co-transmitters, glycine and serine. So clozapine responsive people will have increased glutamate and D-serine, and D-L-serine ratio is less in patients with TRS. So like after giving clozapine, the ratio has increased, which means clozapine is increasing the levels of co-transmitters and it is helping NMDA to act more. This is what is happening. So this is the clinical part to TRS. First we will give first line antipsychotic here, and then 50 to 60% will respond. For the remaining people we will give second line of antipsychotic belonging to another class for 6 weeks duration, and we will see 10 to 20% will respond, and then 30% will not respond. Then we will give trial of clozapine, and 15 to 20% will respond. These people come into glutamate pathway. This is throwing some light, and then if those people are not responding, then we will give ECT. The trial of ECT 10 to 15% will respond. So that's how we, that is the clinical part to TRS. And then, like until here I told, these are some of the newer emerging treatments. So they are targeting, until now we have targeted dopamine neurons, dopamine D2 receptors, 5HT2A receptors and partial agonists. Here these are another mechanisms. See, on a glutaminergic neuron, serotonin inverse agonist and selective serotonin antagonist, and directly on the somtodendritic here and here. These are some of the novel targets. And on the dopaminergic neuron, we have B2 receptor antagonists, but now we are targeting trace amino acid receptors. And then on this cholinergic neuron, we are targeting M4 agonists. And medium spiny neurons, we are targeting PDE phosphatidylase inhibitors. And on the GABAergic neuron, glycine inhibitor and DAA inhibitor, potassium channel modulators. These are some of the novel targets we are doing. Now I will tell some of the newer drugs which have come, and then what are about to come. I am going to tell. Lumateperone, it's a D2-5HT2A antagonist. The mechanism of action, this is the novel drug, like it has some novel mechanism of action. Here, in the presynaptic receptors, usually normal people will have normal dopamine and postsynaptic normal dopamine will take. But in psychosis, more amount of dopamine is released and more amount of postsynaptic D2 receptors will be there. But here, what this will do is, it will act as a partial agonist here. So there will be less amount of dopamine released here. So, see, less amount of D2 dopamine is released here, and there will be less amount of D2 receptors to take in the postsynaptic. So it acts as a D2 partial agonist, presynaptic D2 agonist, and D2 postsynaptic D2 antagonist. This is one novel mechanism of action. That's why lumateperone now people are recommending in psychosis and bipolar depression. And then another new molecule is cariprazine. These are all the newly FDA approved drugs. So cariprazine, it has the distinguishing mechanism of action here is D3 antagonist and partial agonist. So it blocks postsynaptic D3 receptors, and it acts as a D3 agonist here. Here in ventral tegmentum and mesostriatum, it acts as D3 agonist, and limbic areas postsynaptic D3 antagonist it will use. So there will be increased release in the prefrontal cortex. There will be increased release in dopamine. So usually hypodopaminergia is present in psychosis. That's why it's causing cognitive and negative symptoms. But the cariprazine, it is improving negative, affective, and cognitive symptoms. So this molecule has given us a way that okay, now we can treat cognitive and negative symptoms. And this is one more new drug FDA approved, but it is approved in Parkinson's disease only for psychosis. Its mechanism of action is it's inverse agonist, and 5HT2C less antagonist, but more it acts as 5HT2A inverse agonist, so it decreases the levels of 5HT2A, and it has less side effects. But the problem is, since it is decreasing 5HT2A, it has role in negative symptoms. But the problem is there is QT prolongation is observed. So when you are giving in Parkinson's psychosis, you check the ECG, and then you clearly monitor how he is going. And then roluperidone, this is selective 5-HT2A receptor antagonist only. Only it acts, it doesn't block D2 receptors. It is 5-HT2 receptor only antagonist, selective, and it is developed for negative symptoms. Significantly it is decreasing negative symptoms. Other selective in this category are ritonserine, phenanserine and meanserine, but there are mixed results. Some of these molecules we will be using in next 10 years, 5 to 10 years, we can be using these. So that is one novel mechanism of action. And then TAR agonists, I told, these are mechanism. These are trace amines in the dopamine neuron. In the absence of TAR receptor, what will happen is dopamine is normally produced. Dopamine will be taken here in the postsynaptic receptor. This dopamine will take and it will go into this beta-arrestin pathway, and there will be, if there is large amount of production in dopamine here, large amount of dopamine is here, will be circulated and will cause psychosis. But what will TAR agonists will do is they will block this pathway somewhere here or somewhere here, and there will be less production of dopamine here. Or if at all the dopamine that is released here, if it comes here, there it will arrest this beta-arrestin pathway and the pathway will be sidelined. That's how it decreases the amount of dopamine. Getting? So this is one novel mechanism of action, and two drugs are there, ralmeterone and uloterone. This is the full agonist and this is partial agonist. This has shown promising results in phase 2 trials, but phase 3 trials no significant difference in psychosis. So this can be used as an agent, or maybe if in future we may use this as a primary antipsychotic agent. Without D2 blockade, we are decreasing the amount of dopamine release itself. And next is muscarinic agonist. I told you anticholinergic neuron. There are two types of 5 receptors are there. Muscarinic receptors are 5, M1 to M5. But what is important for us is M1 and M4. M1 are present in cortex and hippocampus, prefrontal cortex, and then these are present in the midbrain and striatum. So these receptors are autoreceptors. So they, if we are blocking M4, if we are doing M4 agonists, partial agonists, they will reduce ACH release in the midbrain and striatum, so there will be decrease of dopamine in the mesolimbic pathway. But here in the M1 agonist, they increase GABAergic inhibition. So what they will do is indirectly they will GABAergic interneuron, they will decrease the GABA inhibition in the frontal cortex. That's how it increases the glutaminergic activity. It decreases the glutaminergic activity from top. This is from bottom. This is from up. So M1 M4 agonist called xanomeline. Now it is called Cobenfy. It is FDA approved in 2024 for cognitive symptoms. Okay. It improves positive and negative symptoms, has a potential to treat cognitive symptoms also here. And one more thing is M4 selective positive allosteric modulator, emraclidine. It is also showing promising results. So this will help in decreasing psychosis as well as decreasing cognitive and negative symptoms. And it is FDA approved. So this is one mechanism of action. This is one of PDA phosphodiesterase or intracellular enzymes in the medial spiny neurons in striatum. So inhibition alters the second messenger signal transduction, and by blocking D2 receptors, 4 types of PDA inhibitors are developed. But they didn't show much clinically. Like the mechanism is theoretically fine, but clinically they are not showing so much positive results. And these are, I told you, glutamate requires two co-transmitters, glycerine and glycine. So they are metabolized. Glycine is metabolized by GlyT1 enzyme, and glycerine is metabolized by glycerine amino oxidase. So what we will do is we are blocking this enzyme so that we will improve the amount of glycine and glycerine here, and that will improve the NMDA. That will improve the NMDA function, and that's how we can bring more glutamate into the action. So these two inhibitors, GlyT1 inhibitors, they are bitopertin and icopertin. This bitopertin actually it is developed for improvement of negative symptoms, but it's not that effective. But icopertin has shown good results. So there are many studies on this. So there is significant improvement in cognitive symptoms. And one more, this is glycerine amino oxidase inhibitor is there, lower-taxistate, and this also was first used for negative symptoms, but at 50 mg per day, cognitive improvement is observed. So remember these things. These two will also be coming in the future for management of negative and cognitive symptoms in schizophrenia. And this is one mechanism. This is a parvalbumin is a calcium channel binding protein, and it is seen that this parvalbumin is less in the GABAergic interneurons of schizophrenic patients. So these channels are highly expressed on these two potassium Kv 3.1 channels are highly expressed. So modulation, these channels, potassium channel modulating these things will improve this excitation inhibition imbalance, and that is one mechanism. These are being developed. They are like mixed results are there. We have to see how this will go. So now novel antipsychotics were over, and treatment resistant strategies were over. Then long-acting injectables, they improve adherence, reduce relapse, and lower hospitalization, improve long-term outcomes. So these are some of the newly developed long-acting. This is Invega Trinza. It will act for 3 months, and this is for 6 months. Invega Halfiera. They improve adherence, reduce relapse, and reduce caregiver burden. But thing is, they have more extraparental side effects. Metabolic side effects are there. The question, like what we have to remember is, the question is no longer when to start long-acting. Why is there long-acting injections in high-risk patients? I told you in the first only, we have to reduce the duration of untreated psychosis. Otherwise, it will go into treatment resistance. Then we cannot do anything. So, if we have found that this patient has a high risk, and there is a high risk of relapse, or he will not take medication regularly, start the LAI in the first episode itself. So these are some of the trials they have done. See, RCT and meta-analysis, they have shown early LA prevents relapse, LA superior to all meds, strong real world benefit. So it's better to start LAIs in the initial part of the illness only, when we have doubt that you will not take regular medication. And the other thing is, the next week coming to cognitive and negative symptoms. See, this is the course of neurocognitive impairment. Until after therapy, cognition might improve. Until 2 years, it will be decrease, but then see the gap from LD to. So there is a lot of cognitive impairment in schizophrenia, and then we have to, for every schizophrenic patient, when we are treating positive symptoms, then fine, yes, I did a lot of good work. No, it's not like that. We have to see for how his cognition, what negative symptoms he is having. We have to check with this battery. cognitive treatment emerging strategies, cognitive remediation therapy, computer-based training and NMDA modulators. So the goal here is, I told you, there is no returning back. These patients are completely getting disabled. So our work should be to improve the functional outcomes. So cognitive remediation, it's a behavioral training intervention. It aims to improve cognitive processes, and this is one of the cognitive remediation training examples. So what we will do is how we will improve his processing speed, we will improve his attention span, we will improve his verbal learning and problem solving capacity. We are trying, like we have to try this mental arithmetic, verbal challenges, visuospatial. In these areas we have to give him tasks and improve the, we will try to improve the cognition. This is cognitive remediation, and there are so many examples. And these are NMDA modulators, I already told you. Glycine, deserine, these are 4 transmitters, and glycine uptake inhibitors are the same, and bitopertin has fell short of trials, but it is like activating. These are some of the NMDA modulators which we can use for cognitive and mental symptoms, but no FDA approval until now, not yet standardized. Then digital psychiatry. So this will be dealt in the future, like today only. Next sessions people will tell. And this is also a topic is there for today. RTMS and PVCS. There is reduction in hallucinations and improving cognition. Personalized psychiatry future direction includes biomarkers, pharmacogenetics, and AI guided. See, I told you 60% people will improve with antipsychotics, and the remaining people, some with clozapine, some with ECT, and after that some treatment refractory schizophrenia will be there. Those people. So what we have to do is, we have to take the history completely, and then we have to take the biological things like which metabolizer, he is a good metabolizer or less metabolizer of which enzymes, those things, and then we have to cater individually. Like if we are giving treatment in a fine-tuning manner, then it will be useful. So that we can achieve with this technology. Goal is precision. So biomarkers. See, now we are doing clinical diagnosis. Future, based on his genes, based on his molecules, like whether he is a good metabolizer or a good excretor or not, based on that we can treatment. Moving from symptom-based to biology-based psychiatry. And then pharmacogenomics. So same thing. Whether he will metabolize, is a good metabolizer or rapid metabolizer. Based on that we can give treatment. And then like we can use this technology to predict the relapse, drug response, side effects, so that we can decrease hospitalization, treatment, response and suicide risk. So the take-home message is, if you find any first episode psychotic patient, first give antipsychotics and psychoeducation, and you think something beyond dopamine. Like we have to if they are non-aggressive, if you have any small iota of doubt that he might not be regular with medication, use long-acting in the initial phases only. And then if there is treatment resistance, you give clozapine. Consider negative and positive cognitive and symptom treatment also. And then shift from symptom control to functional recovery. So our goal should be towards that. These are my references.
Sharat sir, Associate Professor, and Dr. Roshni ma'am, Assistant Professor, to felicitate sir as a token of appreciation.
This topic is slightly detailed. I'll be trying to cover very newer things. Some of the things probably you are really aware, you might have heard them, but these are some things which might come as a bouncers in your exam paper. Okay. And then looking into the clinical aspects, in the future probably this could become one of the major modalities of treatments also. Currently I would say there is a mainly of adjunctive, not as a first line or the main lines of treatment. So coming to the topic proper, probably I think most of you have covered the pre-test. In the morning when I seen, I think most of you have scored the majority of the answers. Probably the pre-test was very easy. I believe the same questions will be in the post-test also. So I believe like whoever attempts maybe should get 100 out of 100 in that. Okay. So let's see. Now what I do is that I try to cover almost what are the things which are available as non-invasive brain modalities, and then those where there is a good amount of evidence, those I will be covering in little more detail. So that's what I will be doing. So that will help you out to further go and understand where to concentrate more, right? So at the same time, while I am covering these different modalities, I will try to also touch upon some of the possible mechanisms where or how these are acting. And the indications for this, probably that is where we are gathered here. So there again I will be showing where there is a good amount of evidence and where there is possible you can use it or not use it. Now when we come to non-invasive brain stimulation, the first thing which comes to our mind, or first thing which should come to our mind is ECT. So ECT I am not going to cover because we have as a PGs, as practicing, we have used ECT, we know ECT works. Of course the mechanisms we are not really aware of, almost 100 years are over, so even not touching on that. My topic will be on those things which have been there or which have been developing since past 20 to 30 years. Okay, there are some modalities which have been going on since 20 years, 30 years. There are some which have come up very recently also, right? So why we prefer this? Of course, these are the things which have minimal risk, cost to the patient, at the same time greater acceptability. Most of the patients, if we tell them, say, you need not take medication, just you are going to keep something over your brain, and then you won't have any kind of a side effects, mild itching or something like that. People are really happy also. Okay, and then usually preferred over pharmacotherapy. Again, the caution here is we are not reached to a stage where we are giving only NIDS and not giving any pharmacotherapy. Okay. Now these are some things broadly we can classify. Okay. All are transcranial electric stimulation, magnetic stimulation, photobiomodulation, and last one is ultrasound stimulation. Okay. The name itself will give you an idea as to where we will be dealing. First one, transcranial electric stimulation. There are I think 4 modalities, 4 types, but the major thing which they do is we give electric current, not of ECT, very lower strength of electric current which is used. Again, we know AC, DC from our physics, we use AC, DC based on the type of the modality which we use. In general, all these techniques will have 2 or more electrodes, and then current is conducted between these electrodes when we apply through the soft tissue, that is the skull, and then through the brain. So they move from one electrode to the another electrode. So they penetrate and they pass through the brain activity. So what do? They alter the brain activity. Of course, that's the reason why we are giving the current, and then as it passes through these neurons, and then it changes the activity there. The different techniques here are TDCS, TACS, TRNS. It's very simple. TDCS is transcranial direct current stimulation. The opposite is ACS, is alternating current stimulation. RNS is nothing but random noise stimulation. Okay. Now all these are similar. We apply the electrodes over the skull, but different in the type of electrical stimulation which they use. So current delivered is not powerful enough to elicit an action potential, but rather they are more like subthreshold levels. Okay, so we pass electricity, the amount of electricity used is very low, it won't produce any action potential, but they are subthreshold. Common procedure is two conducting rubber electrodes. They are placed over the scalp using saline soap sponges. Now this is where all the mess comes in, because we need to soak these electrodes in this saline sponge, this one, and then we have to apply it there. We need to be careful. We are not excessively stimulating, so the other things related to that. So attached with the head with non-conductive electric straps. The active electrode, that is the anode, is the stimulatory, whereas the cathode would act as the inhibitor. We'll come to it in little more detail there. When we go into TDCS, the current used is very low, ranging from 0.5 to 2 milliamperes. So what does it do? The current propagates through the head and returns via the reference electrode. That is, from the anode it moves to the cathode. So one-way electricity, at the anode end there is excitatory, whereas at the cathode end there is inhibitory. Now we'll come to a little later on and try to understand why this excitatory and inhibitory are important. The same thing applies to other modalities also when we are using RTMS also. Okay, so this is how the anodal stimulation looks like. So it's more of an excitatory, whereas if you see cathodal, it's more of inhibitory. Okay. The possible mechanisms: low threshold, low intensity electric field is subthreshold, capable of modifying the transmembrane potentials and modulating excitability, brings the neuron closer to firing threshold without eliciting depolarization. That causes decrease in GABA, increase in BDNF and glutamate. NMDA receptors are also involved. Like Ramirez, who had mentioned about this GABA, glutamate, and how these medications, which are newer medications, targeting them. The same thing also done with TDCS. Okay. TACS, we use alternating current. Okay. So here what we do, uses current that is alternate between the electrodes in a sinusoidal way. So again, back to the physics, we have this sinusoid. I'll show you the pattern there. So again, this does not alter the neural excitability, but entrains the neural pain. What is it by entrain? Entrain means when a sinusoidal, we know the sinusoidal how it looks like. So this is how it looks like. It goes ups and downs. Okay. So when we give this TACS, entraining means the neural activity also synchronizes with it. Okay, so that is what is called entraining. So that is one of the concept which is used in TDCS. So this current, again, same thing as TDCS, it alters the transmembrane potential, leading to sinusoidal fluctuation, and alters the local GABA levels, and in turn alters the neural network connectivity. Then there is something called transcranial random noise stimulation. So here, similar to TACS, uses alternating current but differs by using random frequency. So in TACS we have particular frequency and that is what it keeps giving as a machine. But in case of TRNS, that frequency itself keeps changing. So because the frequency keeps changing, it increases the cortical excitability. So among the available TAS modalities, TRNS is better in terms of giving more cortical excitability. So this stimulation ranges from 0.1 to 640 Hz with low frequency ranging from 0.1 to 100 Hz, whereas higher frequency ranging above 100 to 640 Hz. Again, here we have low frequency elicits inhibition, whereas higher frequency elicits excitation. The same principle also applies in RTMS, where we give lower frequency, lower Hertz for inhibition, higher frequency, higher Hertz for excitation. So this is how it looks like when we plot the electrical activity on the X and Y axis. If you see TACS, TDCS, it is very clear, it's sinusoidal, it's very clear, but in case of RNS, it's not so. Now, what are the possible mechanisms for TRNS? One is stochastic resonance. So it induces random activity in target neurons, that is the noise which we give, that boosts the sensitivity of the neurons to further external inputs. Okay, so it sensitizes the neurons. The other one is subthreshold stimulation. So repeated subthreshold stimulation, it prevents homeostasis of the system and potentiates task-related neural activity. So these are some of the two mechanisms, possible mechanisms where or how TRNS acts. The problems with TES, the common thing is with the applying these electrodes. So we need to be careful where we are applying, the region where we are applying, and we need to keep monitoring, because we are giving a lower amount of electric stimulation, but still sometimes it might cause some burns. Now that burns is especially common with TDCS rather than other modalities. So some patients might say with burns on the head, it doesn't look good. So that is where we need to be little careful. Okay. And other than that, they can have something like skin irritation, headache, fatigue. With TACS, skin irritation is quite common, but induces less sensation when compared to TDCS. Whereas TRNS, more of skin irritation, induces less sensation than TDCS. Okay. Then there is other one called as temporal interference. This is again a newer modality. Here what we do is that we give 2 or more high frequency currents. They are directed towards a particular area. So when they are directed towards a particular area, it creates something called envelope. So both these frequencies, when they are directed towards a particular area, it creates an envelope, and that envelope, that stimulates that particular area. So these do not impact the neural activity due to low pass filtering effect on the neural membrane, but this generates a focused electrical field, what we call it as E field, that oscillates at the differences in frequency of high frequency. So this is how it looks like. So 2 high frequency waves, they are directed at a particular part of the brain, and there it creates an envelope, and there it causes changes. Now if you see here, we can focus them even to the deeper areas of the brain. Okay. So when we are talking about RTMS, TDCS, TACS, these are more focused on the superficial areas, but when we come to this temporal interference, even TRNS, we can focus the deeper areas. Of course, in RTMS also there are few modalities where we can focus on the deeper areas, but that is one of the limitations. So in temporal interference, based on those focus, we can concentrate on the deeper areas of the brain. Now when we come to applications, in general, when we speak about non-invasive brain stimulations, it is FDA approvals are more related to the machine rather than the technique. Okay, so this is something which we need to understand. In pharmacotherapy, we say a particular drug is approved for a particular condition. Whereas when we come to this non-invasive brain stimulation, the particular device is approved. Okay, so a particular company, like something like a BrainSwap, so they create a machine and they test that machine in a particular condition. They find the results are approving, and that's how they say that our device is approved. So retrospectively, when we are trying to go and getting a particular machine, we need to see whether their machine is approved. Okay, so that is something which is very important here. So FDA approval among the TECS, among the transcranial electric stimulation, only TDCS, in that it is one only approved condition, major depressive disorder. There are a lot of other conditions where they say that probably it can work, but the evidence is not that strong. Okay, so currently TDCS is the one, again that particular machine is approved for major depressive disorder. Where are the other things which you can use is schizophrenia, anxiety disorders, chronic pain. Okay. When we see TACS, major depressive disorder, schizophrenia, cognitive impairment and cognitive symptoms. Here if we see, they are moving from the major things to other things like cognitive improvement. So this is where in the future, when we are targeting the negative symptoms or when we are trying to address those cognitive symptoms, these are probably the modalities which could be tried. Okay. Then TRNS. TRNS again, if you see here, ADHD, dyslexia, schizophrenia, depression, temporal interference, depression and cognitive enhancement. Okay. When we say cognitive enhancement, when I was reading the articles also, they were saying in the healthy individuals. So this is something we can usually sometimes patient may come to our OP and say that I'm having difficulty, so do something to improve my cognitions. Probably this is where maybe in the future it can work. Okay. So one takeaway important point here I want you to notice is TES, TDCS, major depressive disorder. That is the only condition where it is FDA approved. The rest of the conditions it is not yet approved. Okay. In summary, for TES, different types. There are 4 different types: PDCS, TACS, TRNS, and temporal interference. What are the possible mechanisms? Modulating the resting membrane potential, neurotransmitter modulation, and intriguing oscillations. Okay. Advantages: portable. These machines are very small actually. You can carry them very easily, and expensive wise also they are not that expensive as RTUs. Of course, they are expensive for our current this one. Can stimulate deeper brain areas. Limitations: can have low spatial resolution. So why I say low spatial resolution is our field we are slowly moving towards biological underpinnings. So we are trying to understand what area is involved. For some of the conditions we are really well aware that for example for depression DLPS, left dorsal lateral prefrontal, we know. But then for other areas it is still not clear for other conditions. For example smoking or for gambling or compulsive disorders. We say that these are possible reasons where it could be affected. So we are not very sure. And again, we are not exactly in DLPFC, it's a huge area. So again, we are not sure at what particular area it needs to be applied on. So with that again, this TDCS, TSS, what it does, we are just applying electrodes. We are not specifically focusing on a particular area. We can't focus, we can't do that with any type of TS model. So there what happens, the spatial resolution comes. So we are blindly hitting some areas, blindly trying to find out whether it is affecting or whether it's showing any improvement or not. Okay. So yeah, subthreshold this one requires low impedance with the skull. Of course, there is a lot of air, there is again oil and all those things. So it becomes difficult for this electrical stimulation to pass through. So that is what is called impedance. We move to TMS, transcranial magnetic stimulation. Probably you would have all heard of or seen of, and also probably seen where the conditions it is used. We will go into little detail about this. So here we use these electromagnets to induce currents within the brain and producing suprathreshold E fields. So what it does, overall effect of stimulation can be excitatory or inhibitory depending on the parameters. So a single machine can be used as an inhibitory or excitatory. It depends on the parameters which we use. For example, the pulse frequency and the duration of stimulation. If the pulse frequency is again low, less than 1 Hz or something like that, then it is inhibitory. If you are giving more pulses per the required time, then it becomes excitatory. Okay. So changes in the cortical excitability outlast the period of stimulation. That is why we give repeated sessions, usually spaced within a very short duration. Okay, in a week 5 sessions or something like that. If we go to something called theta burst, we give 5 sessions in a day. Okay, so there are different ways in which it is given. So based on the stimulation frequency, low frequency is inhibitory, higher frequency is excitatory. Same thing is in the TES also. Now these are the different types. Okay. Initially it might look a little confusing, but we'll go one after the other. Single pulse, it is not for clinical this one, it is mainly for research. So when we are trying to find out a particular area, when we want to look at a particular area where we are interested in, we use single pulse. So for example, when we are giving RTMS to the patient first time, we need to calculate something called motor threshold. So to identify the motor threshold, we use single pulse. So when we stimulate that motor cortex, we will have this twitching of the, commonly we see that twitching of the index finger of the hand. So if we are able to locate that, it becomes easier next to locate the DLPFC. So that's how we say it as something called 5 centimeter. So initially we locate the cortical motor cortex, and from then we go anteriorly 5 centimeter to identify where exactly is the, not exactly, where we can stimulate the DLPFC. Okay, so that is single pulse. We give repetitive pulse for our clinical uses. So here we have bundled together different pulses. Again, there are different ways in which it is done. That is what is useful clinically. Okay. So induce effects which are long lasting than the stimulation period. And then there is something called low intensity TMS, which is mostly inhibitory. So we are using low hertz or low frequency pulses. And there is repetitive temporal magnetic interference utilizes high frequency TMS, selectively modulating the deeper areas of the brain. So most of this, repetitive RTMS and all those things, they are, located only to the cortical areas of the brain, but not towards the lower parts of the brain, where we can't reach to the limbic system or other areas which are situated in the subcortical areas. And there is something called theta burst, short bursts of 50 Hz pulses are given. That can induce something called long-term potentiation or long-term depression. Now that is what is important for our long-term memory. That is also implicated in some of the biological aspects of our psychiatric conditions. There is something called deep TMS, which is specifically for deeper areas of the brain. Okay, so there is a specific coil and a helmet. When placed, it tries to stimulate the deeper areas of the brain. And there is something called multilocal TMS, which is shifting and reorienting of the induced event. Now, when you see RTMS, this is how commonly it looks like. So there are different things which are relevant here. One most important thing which you notice obviously is the coil. Again, there are different ways in which it is applied. You have figure of 8 coil, we have angular coil, and some of the companies which have come up with helmets. So that makes our things very easier. With the coil, we need to identify the area, we need to place it particular fixed at that particular place. Patient should not move. We need to fix that. We fix with something like a this coil holder. Sometimes patient keep moving. Sometimes they find it difficult. They won't hold it together. We need to do a lot of ups and downs to keep the patient like that. This one session would last around, depending on the protocol which we use, up to 40 minutes. So those are the difficulties there. So if it is a helmet, even if the patient moves slightly also, it becomes easier to reorient back. With the coil, those are the difficulties. Okay. So now other things which are important here is the stimulate unit and the monitor. Now again, the coil also, there are different types of coils. We have something called air cooled. Air cooled is it doesn't weigh much, but then it gets heated up very fastly. There is other coils where there is liquid coolant which is going inside. As a car, when you are driving, you have something called liquid coolant which cools the engine. It's the same way. So if you have a liquid coolant, it becomes easier time to turn out of the patient. So it takes lesser time for the next patient to start a TMS. Otherwise, the coil gets heated up. It gets it may not be able to stimulate the next patient. So it requires little more time for it to get its it gets cooled down. Now, what are the principles or the basic mechanism which we use? TMS device has a stimulator connected to an electromagnetic coil. That stimulator generates electric current, and that is passed through the windings of the coil which is there inside. Now that generates a strong but transient magnetic field also. So when we place this over the skull, that moves into the scalp and skull, and that induces in turn electric current in the brain. So that is what is important for us. So in cortex, introduces low amplitude electric current that causes depolarization of the local neurons. So it affects vary by location. So depending on the condition, depending on the area which we have to either stimulate or inhibit, we need to locate that area, and based on that we need to give how many frequencies or what inhibitor or excitatory we need to fix. So this RTMS causes repeated changes in the cortical activity by triggering the synaptic plasticity, similar to long-term potentiation. Molecularly, these are some of the mechanisms which RTMS causes, and that's how we see the clinical improvement. So one is induces LTP, long-term potentiation. The other one is long-term depression. Can also alter the genes, expression and enzyme production. Similarly, which I have mentioned in TI, temporal interference, it can also cause entrains oscillator neural network. So when we give those, the neural activity also synchronizes with those waves. Okay. Stimulation target, this is what is important. So in neurosurgery, we have something called neuronavigation. So for example, if there is a tumor, the neurosurgeon is very much focused on where exactly the tumor is. They want to know exactly, centimeter exactly to the point, to precise, to excise only that particular area and not affect the other areas. So what they do is that they do repeated MRI scans and they measure and they keep a something like a cage kind of a thing over the brain, over the skull before the surgery is started, and then they go for surgery. So they know exactly how much to go deeper and all those things. Similar to that is also being tried when we are giving RTMS. Why? Because that particular area is important. If you are initial days when like for example we don't know exactly what area, we just say DLPFC. DLPFC is a large, pretty good amount of area is there. So where to stimulate? So it becomes difficult. So that stimulation target locating is very important, right? But currently we don't go into so much sophistication what we do in neurosurgery. It's not possible, or what we say it is it's a little difficult to go in so much detail. Again, we don't know exactly at DLPFC what particular area and all those things. So that is the reason why we say okay DLPFC, but at least that DLPFC we should be able to exactly identify. Okay, so in depression, left DLPFC is something which is commonly targeted, whereas in case of OCD, there is median prefrontal cortex and angular cingulate cortex. These are the areas in OCD. Whereas in other conditions, there are different ways, different areas. Again, each study or each group which is working on it, they say different area again. Even in depression, there are different areas which are located, which they say, this area rather than DLPFC and all those things. But these are something which are commonly approved across. So target localization is again an active area of research. So when we give RTMS, one is localization, other one is parameters. So how many pulses are we giving? So these are the different parameters which we need to take care. So one is frequency, 1 Hz, 20 Hz or 50 Hz. 1 Hz is inhibitory, above 10 Hz or above 20 Hz is excitatory. So number of pulses which are administered. So when we combine all these pulses together, we say it as train of pulses. Okay. So in this one protocol is set of all these things included together. It's called a protocol. So protocol will tell you all the details: how much frequency, how many pulses, how much is the trains, number of trains in a particular interval, and how much should be the intertrain interval gap, and how much long the whole procedure should last. So that is complete together is called protocol. There are different protocols for each condition. There are again commonly approved protocols for particular condition, right? So number of pulses which are administered together is called a train of pulses. So in one particular protocol, what they do is that they give in a second 10 Hz, 10 pulses of 10 Hz each. So that will last over 4 seconds. That will give 40 pulses in a particular train. And then you have a gap of 26 seconds, that is called as intertrain interval. After that again the same train of pulses forms. So it goes on like that for about 37 minutes. So that is one protocol. So in another one, there is single continuous train. There is 1 second, only 1 Hz, one pulse. Okay. So every second will have single pulse. So it goes on like that. So it's a continuous stimulation. There is something called intermittent theta burst, ITBS. So here you have a burst. Each burst will have 3 pulses, and then 3 pulses are again bundled together to form train of pulses, and that goes on. So there is something like each burst will have 3 pulses multiplied by 5. There will be 15 pulses in a particular train. So it goes on. So the amount of pulses which are giving within a short period are more when compared to the normal protocol in theta burst. Okay. So intensity of stimulation based on the motor threshold again. So motor threshold we calculate, and then we get a particular area, and then based on that motor threshold, protocol might say 120% more than that. So we increase that stimulation to that particular. For each patient, it might change. So once we are established with that particular person, we save those settings, and then when the patient comes to repeatedly, we use the same thing again and again, rather than doing it again, rather than trying to calculate a motor threshold again. Right? Now these are the different protocols, and there are, if you go and search for the evidence, there are different protocols, but I have selected only 2 for depression. These are something which we are commonly using, and these are something which are world across. They are commonly, say that this is more effective, right? So one is using DLPFC, using 3000 pulses of 10 Hertz. You have trains of 75 trains, pulses per second is 40, and intertrain is 20 seconds. So total it becomes to 37 minutes. The other one is, reduce the number of pulses, so it becomes 20 minutes. Similarly for OCD, bilateral dorsomedial prefrontal cortex, pulses, frequency, and it lasts for 18 minutes. For smoking cessation, we stimulate the prefrontal cortex and the insula. We give 1800 pulses of 10 Hertz, 60 trains, 30 pulses per train, 15 seconds intertrain interval, lasting for 20 minutes. So now based on the protocol, the time duration and pulses and the Hertz also varies. Now contraindications, as per MRA, you are very well aware, the similar kind of contraindications. Okay, so if there are some implanted devices, medical devices, especially something like ferromagnet, you should obviously avoid, especially in the head. Okay, so when we are doing the pre-checkup only, these are some things which we need to ask. If there are something they are wearing some tattoos or something, those are also something should be avoided. Those are something like related to content. We don't want to cause all those damages. Deep brain stimulation, subcutaneous leads are placed in the scalp. So the normal accepted distance is 10 centimeter at least. So in case of pregnancy also, we are stimulating the head, right? So baby is not affected, there is a lot of distance. So in pregnancy also it can be given, right? Other metallic devices like chips, pumps, pacemaker, these are something which should be avoided. We need to be very careful. Okay, so even when we are going, we need to remove our cell phones, watches, these things. That can again cause damages. Now, as I mentioned in the starting itself, I mentioned about different, for this non-invasive brain stimulation, these are the machines which are approved, not for the, machines are approved for a particular condition, for a protocol. So these are the, when you see the available evidence, these are some of the things which are approved for. And if you see here in the brackets, they are mentioned about the company also, and some they have mentioned about the coil also. Okay, H1 coil, H5 coil. So again, if you see here, theta burst stimulation for the different conditions. And if you see the FDA approved conditions for those devices, one thing which you can see is depression. The next one is OCD. Right? Now these are all available in a, I'll tell you the details also where it is available. So high frequency RTMS, low frequency RTMS, deep TMS, intermittent theta burst, and other one is continuous theta burst, which is not yet approved by FDA. And there are other different ways in which it is given, something called accelerated TMS, where you give 5 sessions of RTMS and then in a day, continuously over a week. Okay. So again, these are not still, the evidence is not still that great or good. So that is something we should be aware of. The evidence, so this is where you can get this, all the details, clinical practice guidelines, where all these things are detailed and given. How we should apply, what are things, what are the protocols which are approved, whole list of protocols are also given there. Right? Okay, in summary for TMS, we have types, different types based on the pulses, based on the coil which are used, based on the area which is stimulated. Okay, these are the different things. Mechanisms, LTP, LTP. Advantages, suprathreshold, not affected by the intervening tissue, can stimulate the deep brain targets. Limitations, can have high power requirements, can be bulky, expensive. Now these are some things which are not easily movable. So we need to allot a separate space for them. We can't move them. Electric fluctuations, we should be very careful. There are again costly machines. Again, based on the type of frequency it could generate, we require more number of stimulators and all those things. We'll move on to areas which are not very well known to you, but then again the evidence is slowly picking up. Again, the indications for this again are little questionable because evidence is not that great. But we try to just get an idea about this. One is transcranial photobiomodulation. So when we say photobiomodulation, we are using light. But when here we are not using the light which we see in our normal spectrum. Okay, so we will be using something called infrared light. Okay, so 600 nanometers to 1100 nanometers to modulate the brain activity. Hair limits absorption, hence we need to give either on the forehead or intranasally or intraorally. Okay. So uses either continuous waves or short high power pulses. It potential in treating stroke, Alzheimer's disease, traumatic brain injury and depressive disorders. Now these are all the evidences which are there only in some of the few studies. Maybe a small single center RCTs or something like that. So evidence is not very strong. Possible mechanisms. So light that reaches brain is absorbed by chromophores, especially cytochrome C oxidase, that increases the mitochondrial activity and ATP production, that modulates the reactive oxygen species and release of calcium ions, that activates the transcription factors for long-term cellular effects. Evidence, no conclusive evidence for use in depression and dementia, encouraging results in cognitive abilities and brain functioning in aging. Okay. So future will tell us whether this will come out or will just remain like that. Types are continuous wave, pulse wave, intranasal oral. Mechanisms are mitochondrial activity, reactive oxygen species, anti-inflammatory, pro-neurogenic. These are some of the limitations. We will go to something more newer, transcranial ultrasound stimulation. Here instead of using light, we use sound, but again those areas of the sound which are not heard by our human ear. So uses high frequency sound waves for neural modulation. So it penetrates the skull non-invasively and targets both cortical and subcortical areas. So this is something like similar to our ultrasound which we use for normally to scan our soft tissues. So the similar kind of a thing which is used, but here we are not getting it back to getting image, but rather we are just stimulating a particular area, so it can pass through. So higher intensities and longer duration of stimulation, neural excitation. There are low intensity and shorter duration of stimulation causes inhibitory, similar to what is used in RTMS and TES also. Possible mechanism, ultrasound waves induces mechanical strain gradients in the neural membrane. So it alters the neural membrane. That alters the conformation state of the membrane proteins and leads to depolarization. That facilitates axial potential generation via thermodynamic membrane layers and activates the mechanosensitive channels, and that promotes synaptic plasticity, synaptic transmission, and permeates the ion. What are the advantages? It reaches the deeper neuron structures up to 8 centimeters, which are not accessible by other mechanisms like RTMS. Unaffected by tissue conductivity, ultrasound waves are mechanical, better suited to study the neural mechanisms. In healthy individuals, can enhance or inhibit the neural activity. Now, comparison here, if you see, so this is TES inducer, it goes to deeper areas, whereas if you see TMS and TES, they are more of superficial areas. This is the only thing which we can go for deeper areas. Types, we have focused ultrasound stimulation, low intensity focused ultrasound stimulation, and transcranial pulse stimulation. Here what is, I will highlight only this, not approved for any psychiatric conditions, more it is in the research phase, but I have a better idea about this, that TUS is also used. Types, focused, low intensity focused ultrasound stimulation and transcranial pulse stimulation, acoustic cavitation, mechanical deformation and tremor. So high spatial resolution, because we can focus this ultrasound waves to a particular area, can stimulate the deep brain targets, capable of tissue ablation and brain barrier opening, and limitation is limited understanding of the mechanism. It could be impeded by the skull tissue. Finally, take home message, There are majorly 4 different types of non-invasive brain stimulation. Evidence for different modalities is being explored. Why I say is because only few of the things which are approved. For example, RTMS for depression, smoking cessation, OCD, TDCS only for depression. Whereas other modalities are still being explored. There are studies saying that it can be used, but then we need to be careful when we are trying that. So currently the evidence for RTMS followed by TDCS are good and improved. In future these modalities may hold potential in various psychiatric conditions. Right? So any doubts or clarities? My major intention is as speeches I thought you should have a fair amount of idea what are the different non-invasive brain stimulation rather than focusing only on the RTMS. RTMS probably you would have come across and then you would have seen, you would have even applied RTMS. TDCS probably less likely. But then when you have this fair amount of idea, you know where are the different things, where are the evidence is going from.
Presentation, sir. Thank you so much. So my question is, sir, you said for some procedures there is a deeper structure stimulation, sir. So what's the efficacy, sir, compared to deep brain stimulation? That's my actual question, sir.
Depends on the machine which is used and depends on how focused we are stimulating that particular area.
So it might not be as effective as DBS, definitely.
Yeah.
So I mean, is there any proven evidence for, there's a good recovery for the deep brain structure stimulations in these procedures?
Again, it depends on the area. For the particular psychiatric condition, what particular area is involved. Currently, we don't have very good evidence saying that this particular area is involved in this particular condition. Which is saying, okay, probably DLPS. DLPS is a huge area. We are not saying specifically this area if we stimulate, it causes changes. So these are some of the limitations for this non-invasive brain stimulation. Probably in future they are trying to make this neuro navigation so it becomes very easier to identify, pinpoint it out this specific area and then either inhibit or stimulate. When that comes, it becomes very easy.
Thank you, sir.
Then we can name. They have a post test also. We posted there. And so when after you are done with the post test, you can download my PPT also. While after submission, you have a link. So if you click the link, you can download the PPT. Thank you.
I'm displaying the post test right now. Please do scan it.
Until now, we have heard a lot of things. So these are very, very important, basically for practicing and also for understanding the basics of psychiatry. So now this is a modern topic, right? AI. So how many of you have heard the word AI? A lot of them have started using it. Now, though it is a recent discovery, the roots were started in 1960. So that is when the first AI term was coined, right? So it was Alan Turing. He is considered to be the father. So there was one more person who actually coined the word AI, artificial intelligence. But Alan Turing was the person who did a lot of work on this, and that is when recently we have started seeing the benefits. So previously when iPhones were first, when the phones were first introduced, you might have remembered Nokia was the first phone. That was indeed my first phone. So people used to call it as the Nokia moment, right? So then came iPhone, right? So then the world started referring to as the other phones and the iPhone, right? The iPhone moment. So then came in around 2012-13. So ChatGPT was introduced, and that's when everyone started having the ChatGPT moment, right? So after that you have lot of things. So ChatGPT has come. Now you have Gemini, you have Grok, you have recently there's also other OpenClaw. That was a recent one which has come about. So there are lots of other things which are happening in the present world, right? So until now we have learned about psychiatry. There are different terms, right? In MBBS we hardly read psychiatry. It's hardly limited to 1 or 2 questions. But when we come to post-graduation, it's all like when compared with other branches. Our branch is supposed to be something different, right? There's new terminology which we need to read. So some of the branches like dermatology, radiology, it's all new terminology. So now with AI, there's again a new terminology. So there are LLMs. Have you heard the word LLM? So what is it called? It's called the large language model. So there is ML, machine learning. So there are so many different terminologies that we need to know right now. So that is why as psychiatrists, so though we rely more on history. So history is the part where you have to talk to the patient a lot more and you need to understand the basics, right? But we need to be more tech efficient also, right? So now we need to understand the basics of artificial intelligence. So how it is used in psychiatry. So by the end of this topic, you will basically understand how to use AI in understanding the diagnosis, psychiatric diagnosis. So you have seen that right from the morning, you have seen the recent guidelines in the management of bipolar depression or bipolar disorder, schizophrenia, and now the deep brain stimulation, right? So lot of things need to be remembered. Now you also, when you take the psychopharmacology, there are lots of drugs. You need to know which drug to use. You need to know the dosage. Some come in 5, 10. Previously it was easier, right? It was round numbers. But now with the newer drugs like lumateperone, do you know what is the dosage? 42 milligram, right? Pimavanserin, 34 milligram. So the age of whole numbers are gone, right? Even in injectables, now you have olanzapine, which is 105, 210, 205, 315. So there are different numbers which are coming. So all these are, pretty confusing. We need to know the mechanism of action. We need to understand the dosage. What is the minimum effective dose? What is the average dose? What is the maximum dose? So all these are very taxing to our brain. So there comes the AI, which you can use it in our pocket, and by the click of a button we can get all these things in a moment. So everything has changed. So right now we need to change with the times. Okay? So that is a brief introduction. So why is this topic most important? As we know that the population is increasing but the workforce is decreasing. Especially in the West, where a lot of people, they don't want to study for longer duration. So like if you go to US, the medical school takes about 8 years, right? Before that, what we do 2 years of intermediate, they do 4 years. So, and also with the negative population rate. So now they are starting to depend on machines. So that is where, because of the lower workforce gap, so these patients, these countries, they actually need more workforce, so they started using artificial intelligence or machine learning. And also, psychiatry is something different. You know, there are lots of factors which cause it. The food we eat, the environment we grow up. So it is multimodal, right? It is just not, you understand the neurophysiology or neuropathology. There are lots of things that go into the diagnosis of psychiatric disorders. So there are lots of things you need to explain to the patients, especially when you go to a consultation liaison psychiatry hospital. You know, you have to deal with cardiologists, you need to deal with nephrologists. So there are so many other doctors which you need to explain, so which sometimes becomes more complicated. A lot of the times what other people perceive psychiatry as, okay, these people, they come in and they are basically, they call us to, what do they call us for? To sedate the patient. So once a psychiatrist is called, it is only to calm the patient down by giving some drug, some injection. So the basic idea is to calm the patients down or to make them sleep, right? So whenever you encounter a patient attendant in a psychiatrist, so they don't talk about psychotic symptoms, they don't talk about depressive symptoms. All they talk about, నిన్న పడుకున్నాడండి, నిన్న పడుకోలేదండి, నిన్న గొడవ చేశాడండి. No one wants to talk about మనలో తాను మాట్లాడుకున్నాడండి, తగ్గిద్దా లేదా. ఇది ఎక్కువ మనం చూడం. Okay? So that is what we are called for. So there are lots of things we need to be aware, right? So that is why all these things, this AI helps us. So where does AI help, right? So now, in order to diagnose the case, what do we do? So what is the basic thing we do to diagnose? We take the history, we do the mental status examination. So history is what the patient tells us and what the patient attendant tells us. Sometimes the patient attendant can be staying with the patient, or sometimes they might have just brought the patient to us, right? So we always ask the patient attendant side of the history. So sometimes the symptoms can run from days, sometimes weeks, and sometimes even years, right? Who would actually remember what happened last year on this day, right? But we need the exact details in order to come to a diagnosis. Right, what happened on a particular day, or not even exactly, at least remotely what. So there comes the recency bias, right? So people wouldn't know what happened in the past, or when it started, how it started, what are the first symptoms that I've come across, how it progressed, right? When you take the alcohol history, this is what you ask, right? What did you start with? How did you progress? How many did you have? What was your first experience when you had it? So who remembers all that? All they remember is the bad first time or the good first time they had in that particular party, right? So all this, when you need to keep continuously monitoring everything, so AI comes in place. So it keeps identifying the basic symptomatology. When did the patient wake up? How fast did he talk? What are the unnecessary words he has spoken? When did the first unnecessary word he has spoken? So that helps us in diagnosing it early, right? What are the initial symptoms with which the patient presented? lot of the times it is not many people can remember, right? So these gadgets which are in our pockets, they can identify these subtle signs of change and they can give us the data. So we have come from a cross-sectional view to a continuous monitoring system, right? So if the patient or the patient attendant is having a bad day on that particular day, all those emotions come into the picture, right? That is how you diagnose. And you say, what is the affect of the patient? Supposedly he had a bad night, he didn't sleep well, so he might be irritable. Or he had a bad fight with some of them, or something might have happened. So all that comes into the cross-sectional view. But if you know the overall view, how he has been, that is how you talk about mood, right? How was the patient in the past 3 weeks, 4 weeks, or the past 2 months? So that everything will be monitored by the AI. Okay? So that is where the AI come into picture. Okay? So there is something, when you talk about any subject, you need to know the basics. So AI, there is something called the supervised learning. And there is something called the unsupervised learning. Supervised learning is like how you feed the machine with lots of data. Like you give them patient histories, 10,000, 100,000, and the machine keeps learning about from all that, and it comes to or arrives at a diagnosis. So there is something called unsupervised learning, where it itself keeps monitoring and it tries to find out some new subtypes. Like with AI, recently, even in depression, they have come across new 4 subtypes by using AI, right? So these take into the everyday picture of the patient, how they are responding to different circumstances. So it is helping us in classifying much more biologically, or taking into consideration everything into picture, right? So there is something called digital phenotyping. So where you use the smartphone and wearable data, right? Either in depression or bipolar or substance use disorder. So there are different patterns of sleep, right? So what happens is, in a bipolar, they are as energetic as they have slept for 8 hours. So they wake up by 3 a.m., they start their work. So there's something called actigraphy, right? So depends if the patient is in a manic or a hypomanic mood, the way they are typing, the speed they are typing, right? What hours they woke up. So all this is taken care by the wearable devices that people are having right in their pocket, right? All these data is taken into consideration, and it will help us in arriving at a diagnosis much earlier, right? So we can identify the disease at a much earlier time than when patient walks into the OPD with a full-blown picture, right? So that is very, very important. Okay. So this is something called natural language processing. So these are the the technology is hampering even the regular flow, right? So yeah. So natural language processing. So these are the immediate tools which are being used in psychiatry. So basically what we do, right from the thing when the patient walks in, you ask the questions, you keep jotting down the history, right? So you have to identify the patient right from what are the good clinical skills, how do you do? So right from the where my professor or you used to say that as soon as a patient walks into the OPD, that is when your observation of the patient should start, right? So you have to maintain eye-to-eye contact, right? You also have to take the history, you need to understand the expressions, you need to jot down notes. So all this has to be done at the same time. What if you're only observing the patient and rest of the stuff is done by gadgets? So there comes the electronic scribes, where you have automation and you keep talking to the patient, and there's this small machine which keeps running in the background. It keeps jotting down notes instead of you writing down everything, So that takes care of that. So you have more time with the patient, right? So even before the patient walks in, what if all these things are done by the wearables that you're wearing? So when the patient walks in, you have the history right in your pocket, right? So and you can ask more questions or the necessary questions to arrive at the diagnosis. So all these things are made easy by using artificial intelligence, right? So this is the basics. So AI for predictive analysis and prognosis, okay? So this is whether to identify a psychotic patient or when is the time when the patient is actually going into psychosis, or what is the first sign. So in order to identify all that, so the AI helps us, okay? So high risk cohorts, so they machine learning. So how useful is this? So when compared with the physician diagnosing the schizophrenia, what if an AI diagnoses the schizophrenia? So they have seen that it is around, in high risk cohorts, it actually has a sensitivity of 76 to 88%. So which is okay, pretty good, right? So, and there is also a 85% balanced accuracy. So there is something called the detect system. So recently all the colleges, they are, instead of us writing, they are asking us to upload everything, right? Electronic health records. So that has become recently, even our college has started doing it. So when we have these electronic health records, so there is the data, lot of data that is available that can be used for research. Previously wars, now the recent wars which are going on are because of oil, right? So there's some war which is going on, your oil price decreases, increases. So based on that, everything changes. Your daily household prices also keep changing. So now with AI, so they have coined this phrase, data is the new oil, right? How many of you have heard this phrase? Data is the new oil. Right? So now with AI, you have lots of data, you have lots of things that are being done by electronic gadgets. So these help us in identifying these symptoms much earlier, in designing the systems more, right? So for all this to be done, there has to be clear protocols. There have to be validated protocols. We have to have because these are all stored in a machine. So there has to be protocols for data privacy. So that is very, very important nowadays. right? Data privacy is the most important thing that we need to be aware of. So all these protocols have to be taken into account before we can implement all these recent technologies. So as you know, psychiatric diagnosis, as I was previously telling, it is multimodal. So these unsupervised AI techniques, they help in identifying the biologically distinct subtypes. So there is something called dimensional neuroimaging endophenotypes. So if you see dementia patients, so there are lots of things we ask them to get the MRI scans done. So what if all these things, if you can identify these scans and you upload them into a machine and see whether there are earlier signs, whether the patient, based on the family history or based on various data that we have accumulated, we can find the earlier signs of dementia. So a lot of the AI techniques or AI programs, now they are useful in certain diseases to identify the disease at a much earlier date. Some of the diseases which AI is presently, they are being used as depression. Okay. If you come to the age groups, some of them are being used in adolescents and some of them in the elderly age population. And if you come to the particular diagnosis, some of the diseases which are being used, AI is being used as depression is one, bipolar is one, and dementia is one, and in children ADHD, right? So because of the various activity levels, various places where we need to identify the activity, so AI is making a mark in identifying this diagnosis at a much earlier time. Okay? So where else AI can be used? So as I was talking in the introduction, you need to understand whether you have to give medicines, whether you have to go for counseling. Now with newer modalities, whether we have to give RTMS, DTCS. Okay, now sir was talking about ultrasound modulation. So all these things with the data available, we can choose which treatment is better for a particular person, right? So AI will help us in this process also. So some of the recent ones are the psychotherapy. All of you might have heard about CBT, right? So a lot of the times for depression, that is how we ask the patient to write down and we try to analyze the whatever situation they were in, how they have reacted, how did they act upon it. So there's something called the V-bot, right? So this V-bot, it's an automated chat bot where you can talk to the patient, where it talks to the patient and it keeps on taking notes, it analyzes them and it gives out treatment. So one of the advantages of having this therapy is, you need a particular time. If a human is involved, you need to involve them at a particular time. You cannot prolong the time. Sometimes we have other patients to take care. But these bots, they're easily available in your phone. They can talk to us for hours, right? And they keep collecting data. And they keep analyzing the data and they give out proper responses, right? So this is some of the use cases. So this is one. And there is also something called avatar therapy for schizophrenia, right? So there is avatar therapy where in schizophrenia you have delusions of persecution. So the voice modulations, so in avatar therapy what they use is, they use our voices, like the persecutory voices, they have different kinds of voices, and they use the treatment like the relaxation or the dosages of the drugs. So this AI model trains to relax by giving out different scenarios so that the patient can be made very well aware of that. But what is the raw side of it, right? Patient is already psychotic. Some patients have the view that they are already observing, right? Some feel that their phones are hacked. So how do you think they would react when they would know because all this has to be told to the patient, right? You just cannot take the data without letting them know. So you have to talk to the patient, and once you talk to a psychotic patient that they will be observing you through your phone, I don't know how they'll take it, right? So that is one drawback that we need to be aware of. Because anything we do, we have to take the consent of the patient. So when you're talking to a psychotic patient and you say you'll be observed 24 hours, 365 days, so I don't know how many people would give us, or whether we will be helping them with their psychosis, or whether we'll be increasing the psychosis in that particular patient. Right? So all these things had to be made aware. So there are also certain things like AI and autism spectrum disorder. These are some of the disorders where AIs make them marked. So these are some of the social robots like Casper and Neo, right? So they are particularly engaging for children for ASD, right? So they practice gauge. So when you have autism spectrum disorder, these children, they don't have active gauge, right? They don't engage the gauge. So that is what these robots will help us. In order to properly treat a child case, rather than the role of a psychiatrist, it is the other people which play a very important role, right? So you need a proper team. You need an occupational therapist, you need a clinical psychologist, you need a physiotherapist. All these things, all these people play a very important role in properly treating a child case. So this is where the AI comes into it. Like now, there are robots which are replacing the person. Okay, you are giving them skills, you are teaching them skills, and they would, in the future, would act as agents, right? So these are some of the social robots, okay, like Casper and Neo. So when they have done the studies using these robots, so these studies, they have reached a sensitivity of 76%, and they also have a specificity of 92%, which is pretty good, right? But always remember, don't over-rely. Right? Just because you have all these fancy toys that can be made available, just don't the human element, the human touch, the human experience, that they would be lacking in these fancy gadgets, that what I am talking about, okay? And sometimes you cannot over generalize. So you have a particular set of patients which are treated, and sometimes you also have some diagnoses which are based on the customs, right? So if you take all these AI which is coming into picture, so all these AI data which has been collaborated are done by the Western countries. So their lingo would be different. It cannot be used to someone in India where we have different dialects, right? So what I was talking about, identifying the prodromal symptoms in schizophrenia by identifying the way they talk. So whether it is a cultural thing or whether it is a disease, first initial sign of the disease, that cannot be generalized, right? So all these things you have to take into account, okay? And the most important thing is privacy. Okay, so these are the different digital biomarkers like sleep, activity, speech, prosody, keystrokes, that how you identify in a bipolar patient, like how fast are they typing, like how in the history you ask about how fast are they talking. So whether they are jumping from one topic to the other topic, whether they are making sense. So all this will be identified by AI. Okay. So before doing all this, informed consent is very, very important. Everything has to be transparent, and you have to make sure that they have proper encryption, right? So all these data, you need to make sure that these are safeguarded. Because now in Andhra Pradesh, we are talking about quantum computing, right? How much of you know about quantum computers, right? So all these bank codes that you get, right? When you get a OTP, all that is generated by a computer. So there is hundreds of persons who are making transactions, and each one of you get a code, right? So once you put in the code, that is when your transaction would be done, right? So it is all that is done by a computer. So this quantum computers are with thousands of computers put in, and if there is a powerful computer that can hack through this system, so all our accounts can be hacked. Right? That is the power of quantum. Right? That is why now people are talking about cryptography, blockchain. So in the future, especially in the US, people have started putting their data onto the blockchains. Right? Blockchain where the patient data, where you cannot change it. Right? Now the records can be manipulated. Not once you put it in a cryptographic form. So all these things are the future where we are moving from history, we are moving from technology to more and more advanced technologies. So we need to be aware of all this. Okay. AI, as I was talking about dementia, they take into account all the scans like MRI, PET scans. Okay. Previously, when we were talking about CT or MRI, especially with psychiatry, because all these scans, they are very expensive. Like now we are writing CT scan almost like it has increased in use. But when because we are trying to move towards biological aspects of psychiatry, but cost is always a constraint, right? But now all the scans which are becoming cheaper, so that is when psychiatry started developing much more. So all these things which we are talking about, dorsolateral prefrontal cortex, or the different areas, ACCs, which we need to stimulate, all this has come into picture because MRIs, PET scans, they've started becoming at least affordable in the Western countries. Even now they are very, very expensive in the Indian context, because if you take the PET scan, which is normally used by oncologists to see about the various spread of cancer, it costs around 35 to 75,000 per scan. So if you want to identify and understand, it is pretty much not very pocket friendly, right? So all this data which we are having right now is the Western data that we are using. Okay, there is something called the genome, right? So all the Wilson and Crick, when they started with the DNA, so that all thing has been studied, right? The Human Genome Project, which a lot of people know or would have known, that it has been completely done in around 2010-15, right? So all that things, when they are fed into the computers, they can identify which genes are responsible for a particular disease. Okay? So these, in the future, you don't have to prescribe a particular dosage, because all this will be identified by the human genomic structure, and we identify what are the healthy genes, unhealthy genes, and we also start treating the patients on the genetic levels. Okay, so these are the future. And recently there was an article where a man using ChatGPT and genome structure, he was able to cure his dog completely free of cancer. Okay, so that is where the AI and the technology has progressed. So these are some of the guidelines. So the key principles, as I was telling you, is transparency, informed consent, bias mitigation, data privacy, accuracy, human oversight, clear liability and accountability. You're taking all this data, you're storing it in a computer, you just cannot leave your computer wherever you want. So you need to be accountable for all this data. So these are the things you need to take into consideration. So the WHO perspective, so you have to have a human element into the guidelines. Okay, so WHO has said that even though you have all this data, you are making these guidelines, but definitely a human has to be involved in taking the final say. Okay. So these are the Indian guidelines. So this has been published in Indian Journal of Psychiatry in 2024. So same thing, emphasis is on clinical oversight, patient selection, informed consent, data security, and integration into step care pathways. So these are very, very important for Indian settings. So whenever you are talking to the patient, you actually have to talk to the patient. So that is what you do, psychoeducation, right? So you need to give out everything to the patient and let them decide what is important for them. So same thing with AI, when you are recording all these data, so you need to make them aware that these are the tools which we are using to collect the data. Talk to them, explain it for its purpose. You also talk about the risks, benefits that they have with these, and always take the informed consent. So that is very, very important. So when you are taking this data, so in day-to-day practice, you have to have these consent forms, you have to document everything, you have to use visual aids, and you have to use the plain language, the language which they can understand. Okay, this helps us in building trust. So the first, where if you see, that is very important to give out the intricate details. So as soon as the patients walk in, it is very important to have the empathy part of our side. In the same way, it is very, very important to develop trust. So without taking the patient's trust into consideration, you use all these electronic gadgets, definitely we would arrive at a wrong diagnosis, right? So that is very, very important. So these are all the advantages that AI can have. But if you see, what are the limitations, right? Diagnostic accuracy remains at 48 to 62%, so which is pretty low, right? So based on all these data, AI can tell you which case is at risk, won't be able to identify the exact, it can only tell you how severe it is, or how bad it is, or how mild it is. But the final decision has to be based on all that data that has to be taken by the psychiatrist. So in spite of having everything in your pocket, you need to understand the intricacies, why we need to understand all the genetics, the psychopathology behind the disorder. All this we need to understand to take the final call on our patients, right? So common barriers are, you need a lot of technology that into our practice, so which sometimes can be expensive. You need electronic health records, you need staff training, right? In order to analyze all this data, you have to either get trained yourself or you have to train the staff, which would again increase the cost. Okay, so these three practical examples are the detect system, which I was talking about. So detect in the sense, so you are under constant surveillance. So every word you speak, every small thing you do, that is being analyzed. So that is the detect system. So, and I talked about VBOT in CBT, and there are also, when you have chronic high risk patients, so that's when AI can definitely help. So to come to summarize, so AI currently delivers greatest value in risk stratification, continuous monitoring and decision supports. So you need to have essential guidelines or guardrails to maintain transparency, to have consent, to mitigate bias, and also to have that human oversight. So all this taking into picture will have a clear actionable direction. So we have to remember, AI is here to help us deliver better, more equitable psychiatric care, provided we are under control. AI has to be under our control. We should not be under AI's control. Like how an alcoholic would say, like tomorrow I can stop alcohol. So the alcohol is under my control, which as psychiatrists, we know that is not the case, right? So don't develop, as psychiatrists, we are necessary to treat addiction. So just don't become addicts to AI, right? So I want that message out clear and loud. Thank you.
Legal checklist is the main one, followed by the financial checklist. So this is a very, very important one. So the first one is the budget. So initial budget before starting the clinic. So and the planning the budget and how long your budget will be there, that depends upon entirely how your clinic runs sustained in the future. Okay. So budget for setup, which is a one-time investment. So before that you have to choose the location wisely. So there is a portaling law, what we call it as the principle of minimum differentiation versus maximum differentiation. So for example, if you take the cobbler shops, all the cobbler shops are placed at one place. While you take ice cream shops, they will be at different places in the city. So if you take the Nakal Road in Vijayawada, all the doctors are placed. So if you want to place your clinic at that place only, or if you like maximum differentiation, if you want to place somewhere away from the city, it's your wish. So on which law you will follow. But both are in medical practice, both are profitable. So because most patients, if one clinic the doctor is busy, so they will go to the other clinic. But at a different place means only that catchment area people will come. Of course, they wait for some time. Okay. So and also your practice also depends upon it, how you expose and what is the niche area which is specific, how you practice and what is the need in that population. Whether you can practice child psychiatry, de-addiction psychiatry or sexual medicine, whatever may be the, so separate niche area where there is a need. So the cost include the initial security deposit for renting the clinic and interior designing for welcoming and waiting areas, consultation rooms, and minimum equipment for psychiatry practice like BP monitor and stethoscope as of now sufficient with the RX pad. Of course, if you want diagnostic equipment like ECG is needed. Okay. So and after COVID, we have seen that electronic medical register and clinic medical software has come. Initially, during the time of COVID, they used to provide for free, but now they are charging like Bajaj Health Fins and Practo, Apollo 24/7, so Librate. So these are all these things you can use their clinical management software. Of course, separately for your own clinic, there are other softwares also. So licensing and the legal fees we already discussed, and very important is first you have to take after your post graduation indemnity insurance, professional indemnity insurance. So this is the one which helps you or which safeguards you when some patients approaches legal authorities against you. So that is very much about 5,000 to 10,000 for 1 to 2 crores indemnity insurance. So and there are certain organizations which are favoring the doctors in providing alone the indemnity insurances. Okay. So initial stock of consumables like medicines when you start pharmacy, and marketing and launch campaigns which are discussed in detail. So recurring operational costs about the staff's salaries, usually you can keep a research list, of course 10th or 12th grade completed. So housekeeping for keeping the clinic neat and professional, and nurse if you want to manage any injections and all. Okay, and lab technicians if you had additional lab facilities. So utilities like electricity, water, sprinkler and internet which are essential needs, and software subscriptions for clinic management software and electronic medical records, and insurances are required, and renewal of insurances every 3 to 5 years for fire and LOC, even postgraduate registration renewal, clinic registration renewal every 5 years. So many, these are the recurring operational costs, and maintenance and repairs. So funding options, so it depends upon how, so as my career went, so I started in a private hospital as an SR and assistant professor. Gradually I started the evening clinic, and gradually when I got the enough salary and all, later I completely moved to the private setup. So that is the usual suggestion, okay, I give. So and of course personal savings or banks and NBFC, so Bajaj Finance will give up to 50 lakhs if you are having a PG certificate, and if your spouse is also doctor, they will give more amount. Okay, so specific loans by the banks and government schemes like Prime Minister Employment Generation under MSME. Okay, and angel investors like Aster, Apollo Group, which they themselves take part in your clinic or in your hospital with ownership equity or commercial debt. So so we always want to be autonomous and autonomy and free in giving the personalized care to the patients. That's why always we plan to start as a single doctor clinic, that is a sole proprietorship. So it is best for solo doctors, but advantage is complete control of what treatment and what type of medications, what type of investigations is under your control, and with no pressure from up. Okay, but entire liability is on you. Okay, there is no liability protection. So if you had partnership, of course, for example, if you take in Hyderabad Asha clinics, so multiple doctors at the single place, So if you want to be as a part of those hospitals, you have to pay certain amount and become the equity of the proprietorship will also be given. I think in Vijayawada there are no like that, but in Hyderabad and Bangalore so there are so multiple psychiatrists who are one in schizophrenia, one in bipolar, one in anxiety disorders, one in de-addiction. So they themselves together with typical mindset, with unique similar mindset, they come and start the clinic. So otherwise, you with your other colleagues in other departments, you can start the partnership clinic, so multi-specialty clinic, which there will be sharing of the both profits as well as liabilities. So private limited company is mostly these big hospitals like Aster, KIMS or Ramesh Hospital are mostly corporate hospitals which are private limited. So and this depends upon how your practice will be, so that revenue sharing as well as when your clinic will be profitable, as long how much income you are getting initially and how much you are putting back in your clinic for extending your clinic or for buying the new equipment and all. So when you will become profitable, this entirely depends upon your practice and all, footfall of the patients. So it also depends upon your long-term financial planning. So you want to estimate the patient inflow, about the consultation fee, whether we have to keep, so in comparison with the other members in the same catchment area, or with any increased amount if you are giving specific niche which are in need and all. So financial buffer for the seasonal fluctuations, we know that during December and January there will be very less number of patients, and of course if COVID comes there will be very less number of patients and all. Okay, so and when is the break-even point, when your clinic will become profitable and all. So for all this you may take a professional help from the CA. So daily operations checklist. Okay, so where you locate where you keep put your clinic, it depends entirely on how you will be thinking, whether with other colleagues or whether you are alone at a different catchment area. So for that you always need to do campaigns and camps going to the surrounding areas in your catchment area and all. So always accessible, visible from the main road with parking and wheelchair access. So clinical infrastructure, so even for getting uploaded into Google and all, you should have photos of your waiting room area, reception area, consultation room area. You have to take photos and upload, then only they will accept you as a referral point in your Google My Business. So equipment of course for us will be less. Hiring the right team like receptionists, nurse, lab technicians and all, and communication channels which we'll discuss in detail. So this technology and digital tools will help you decrease the manual paperwork and will make you future proof in of your clinic, because now entirely everything will be digital. Okay, so you have to get the clinical management software with the digital payment systems like PhonePe or Paytm Business and all. So automate communication initially with so SMS or WhatsApp reminders to the patients, or when so I always suggest to keep 2 phones, one with the receptionist, so and or with you, initially with you only. So one phone you can, that phone number you can give to the patient in for communication when there is any emergency, and when one phone completely your own without any giving to the patients and all. So the other phone number you can provide, and with WhatsApp if patients ask any doubts about the medications, any side effects, you can always contact. So that increases so that your unique therapeutic relationship with the patients. So always protect the patient data according, of course the law hasn't been approved, so we have to Digital Information Security in the Healthcare Act may be passed in nearby Parliament. So very important is the marketing and visibility. Okay, so this marketing shares your success. So nowadays entirely digitally, and what we say is Google My Business, Practo, and digital marketing, what we call as a digital mouth publicity and all. So we had online like Google My Business, your own website, healthcare listings in Practo, Library. Okay. So and very important is to review. So how much reviews you get in your Google. So the more the reviews in your Google, the first 3 are shown in the if you search psychiatrist in Google, so only the one who are having more than 100 reviews or who are the first in the reviews, that 3 psychiatrists will be immediately shown. So that's why very important is to get the Google reviews. Okay, so offlines by having the word of mouth publicity by arranging camps or outreach clinics and all, or using flyers and all in the newspapers, etc. And you should have very much contact with your nearby colleagues and also who can refer you for patient is having psychiatric illness. So consistent branding will be help you in recognition over time. So the key principles, I suggest is to initially join as an SR or assistant professor at a medical college, nearby medical college for 2 years, and consolidate what you have read during your post graduation, and gradually, so maybe you start evening clinic and gradually, so you can increase to the full time private setup and all. So this is how my journey has started, and most of the, so there are some of my colleagues who started directly and they are very good in the practice also. So it entirely depends upon your financial and your effort to do your, okay. So if you are setting up immediately, and you should set up very effectively. So and grow in a sustainable manner. So initially, so when there are no patients, also you have to be there available in the clinic around the time. Okay, and maybe at that time you can use the digital tools to improve your publicity online. So and always safe, stay legal and within regulations. So this may not be happen, nothing will happen till no incident happens, but if any incident happens, the first thing they will ask is whether you got registered, whether your clinic got registered, whether you got fire and OC. So always better to have these legal licenses and practice within regulations. So and very important is maintain good relationships with your colleagues. Okay, this will help you in long term. So after this we can go with the emergencies in psychiatry. So these emergencies in psychiatry, I will discuss mainly the major emergencies in psychiatry, how to deal them, especially in private practice. So when you are alone or with a minimum amount of staff. So we also call them as behavioral emergencies, which we can define as the acute disturbance of behavior resulting from the thought or mood disturbance of the patient. If untreated, either may lead to harm to self or to the immediate surroundings or to the society. So it differs from the other medical emergencies because there is a harm that may happen to the society. So of course, even in medical specialties for medical problems, if they come to the ED, even those having maladaptive personality traits or coping skills may also present with where the immediate psychiatric consultation is needed to the ER. Okay. So and always in emergencies, safety. So then therapeutic, then treatment. So the safety or security first paradigm intervention has to be followed. So first to initially contain the patient from his behavior harming himself or to the nearby patients or nearby staff and all. So rather than treating the underlying psychopathology. So coming to we can differentiate into major and minor psychiatric emergencies. So major include the self-harm in the form of suicide or agitation leading to severe form of violence, and other medical emergencies that are related to psychiatry, especially delirium tremors, where the other hospital will call you for consultation and all. So delirium which can lead to life-threatening if proper not treated, whether it is because of substance intoxication or withdrawal, or because of the medical drugs, or because of some medical conditions like metabolic conditions like hyponatremia or hypoglycemia and all. So and overdoses of some psychiatric medications and all, especially those who are having anticholinergic activities and all, or those presenting with EPS, dystonias and all. So of course with rarely neuroleptic malignant syndrome and serotonin syndrome, and overdoses and withdrawal from addicting substances and NMS and serotonin syndrome, while minor include grief reaction, rape and disaster and panic attack. So we all know the risk factors for a patient, for an individual who is having suicidal ideation and who is in future very high chance of committing suicide and all. So the most important risk factor is depression, followed by the alcohol or other substance use, followed by the organic conditions of schizophrenia, or having the prior suicide attempt. So you can remember the mnemonic sad persons, which are the risk factors like sex, age, depression, then previous attempt, like that. Okay, so reality testing. Okay, so these are the various risk factors you can think. So I won't go in detail about that. So of course the warning signs you can remember by the mnemonic path 1, and the protective factors like being married or having children in the family, so consistent job, and also all these family environment, all these are the protective factors. So immediately you have to assess the suicidal, so you can use various other tools like BEX or other suicidal ideation scale, and we all know that immediately asking about the suicide, you have to ask every patient who's having psychiatric illness, and asking itself does not instill any ideation or increase the chance of committing suicide. So and patients most of the time they feel relieved when we reassure that having these ideas is also part of illness, and you can overcome by thinking about your other children, and also what coping factors you are dealing when you are getting ideas, and getting these ideas are a part of illness, and how you are coping these ideas, this will all help you. So, and always those who commit suicide, they always give hint. So in the form of writing suicide letter, or stopping using the medications, or suddenly there will be change in the symptoms without having any symptoms, as I am going to die, I should have this sadness and all. So immediate management in the form of either ECT, ketamine is very helpful, and of course we know that lithium and clozapine have additional anti-suicidal properties. So of course there are other crisis intervention centers and helplines. Immediately you can call like telemans by the demands and all central government. So where almost entire time there will be one available for listening to the patient having suicidal ideation. So next is when the patient is having impulse control problems, when there is acute conflict in the family or in the work environment, all there is a high chance of impulsive suicide attempt or impulsive deliberate self-harm, which have to be recognized and treated as needed. So, and of course those having, especially females are having borderline or emotionally unstable personality disorder, there is a high chance of recurrent suicide attempts and or recurrent deliberate self-harm. So of course having low intelligence and having dementia, there is comparatively less chance of committing suicide or having suicidal ideation, but that can also be happening. So we're coming to the excitement and agitation, which can finally lead to the severe violence. So this can be the agitation or violence can result from many ways. So even regular psychiatric disorders like schizophrenia, when there is acute psychotic breakdown and all acute psychosis, or when in case of depressive disorder, when the patient stops medications, it becomes agitated, especially in the elderly and all. So along with when the patient is having maladaptive personality traits and all, especially alcohol intoxication, or when the patient is in withdrawal, want of immediately alcohol and all, or agitated, confused, having hallucinatory behavior and all. So or any intoxication, especially with cocaine or hallucinogens, or any head injury, or even due to other metabolic conditions causing metabolic encephalopathy. So any of things can increase the tension or excitement in the patient and lead to severe violence. So so what the principles you have to follow in dealing with the agitated patient is very much important. So we'll discuss in detail. So these always you should be safety to the patient and safety to yourself and safety to the other staff and other patients in your clinic and all. This should be maintained. So always you should be ready to ensure immediately recognize what are the signs and symptoms the patient is presenting, immediately recognize and how to contain, whether using physical or mostly as least as possible, better least use physical restraint, mostly better use the psychotropic medications like haloperidol or lorazepam and all. So if the patient is accepting orally, better give more dissolving tablets which comparatively acts faster than the oral medications. Or if not, you can give the injectables. So signs predicting the impending assault include anger, so excitement, whether it is secondary to intoxication or secondary to sometimes panic attacks, or sometimes very much in private clinics seen is the dissociative attacks and all. Okay. So demanding immediate attention, loud with shouting with a loud voice and all, staring eyes, flared nostrils, flushed face, which show that they are very much anger. So hand clenched or gripping, so restlessly pacing in the room and all, pushing the furniture, slamming or throwing objects and all, uncooperative and suspicious towards the examiner. And of course, in our country, possessing weapons is less, but in USA and where the weapons are legal and all, so they may possess weapons and all. So and sudden movements of the patient, you should always be careful. So coming to the strategies to prevent, so always you have to keep calm and soft, and so rather than dealing the risk factor or the underlying pathophysiology, better talk about the what the agitation is having and immediately solving the agitation, and be empathetic and calm. And why calm means because always be better to verbally de-escalate, because if you non-verbally or if your body language is somewhat threatening, this will always reflect in the patient, so he may react impulsively. Okay. So keep hands visible, that so that the patient doesn't feel I am not getting injected or I am not getting restrained and all. So always keep the door open, immediately security and other staff nearby, and don't stand in front of face to face. You have to stand by the side. Okay, better, so that if we get aggressive also, it will take time. So that you can use your hands as well as legs to protect if he is trying to clench or trying to. So stay at the side of the patient, stay at least an arm's length away from the patient, use non-threatening body language, that is very important, and use reflective statements rather than judgmental ones. This is very, very important. So always call for help if you have ward boys or ward nurses and all. So like other panic buttons are like code red or medical emergency and all. You can for psychiatry also, especially in the ER rooms where there is a multi-specialty or medical college, you can always have some separate code which can help, so that immediately the department, psychiatry department or other ward boys or the security staff will immediately come to the emergency and all. So, and if he is trying to kick, better protect with closed hands and legs. Escape also, always in your clinic you should have your entering door, and where you have another door where you should always escape if the patient is becoming agitated and all. So physical restraints, but as much as least possible. Better is the haloperidol. Of course, now olanzapine injections has come, glupentixol injections has come, insta injections. So olanzapine more dissolving or lorazepam more dissolving, which I use frequently and all. So then you go with the haloperidol or lorazepam injection. So haloperidol 10 mg, so up to 60 mg, but always in the cover of either phenylpromethazine or lorazepam to prevent immediate dystonic reactions and all, which will be again creating problem for the patient. So after controlling in a non-judgmental way, after containment or sedating or the agitation, then go for the careful history, and always what we call it as a medical clearance. Of course, this is not an universal accepted form, so everything, whether psychiatry or medicine, it's a medical. So always look for the other medical causes, especially. So I had typical experience in my post-graduation. I have called from so he's a patient with schizophrenia. So they call that he is having psychotic breakdown, come and see. So I went and saw, so routinely I asked for the GRBS, then it is 40. So he is also having comorbid diabetes. So on the day morning, he missed his breakfast but took his diabetic medication. So because of his hypoglycemia, he developed the agitation symptoms and all. So always better have knowledge of what are the medical conditions that will develop, that manifest as the psychiatric symptoms and all. Okay, so careful physical examination, laboratory studies to rule out them. So prevention, adequate security staff, access to examination rooms and treatment areas should be limited. So only patient, the mob shouldn't enter once. Okay, should have at least 2 exits. A call button should be required, and all suspicious patients should be watched for a long time, at least 8 hours, or if needed up to 72 hours. So to conclude, so as a mental health clinician in the emergency room or in case of emergencies, whether it is psychiatric emergencies or psychiatric manifestations of medical emergencies, you should work as a consultant, liaison with the medical consultant and educator to the bystanders and all. So what is the problem, what created the problem, the psychiatric manifestations are in fact because of his medical problem like that. And you should also be somewhat detective in detecting the signs and symptoms when the patient gets severe violent and all. So you should be good at managing hospital system issues like protocols. Of course, there is no specific protocol. It should be tailored according to the individual patient needs. So informed on the medical illness and their psychiatric manifestations, skilled in conflict resolution with both verbal de-escalation and non-verbal body language and all, calm and ethically, and at the same time legally informed to get Form E signed if you are keeping patient for 72 hours. So if you are discharging or not, again you get Form E signed again by the bystanders, where you get it signed for according to MHCA support, high support needs every 72 hours and all. So always responsible for patient safety and safety to self and other staff. And so in emergency practice, it is both safe as well as therapeutic. So as possible, tailoring the approach, addressing the agitation rather than the underlying cause or pathology, containment with the least restriction possible with verbal de-escalation. So many patients resonate with non-verbal communication and always vigilant about signs of escalating tension and appropriate, so immediate admission and immediately as soon as possible discharging the patient after controlling the agitation. So after safety ensured and overriding the agitation, rule out always the underlying medical causes which are maybe life-threatening if not found. Thank you. These are my references. So any doubts? The private practice, setting up private practice. This is at most where it is not discussed entirely your post-graduation, entirely depends upon your artistic flair or your natural talent, how you increase your footfall, how you manage, how you develop your unique therapeutic relationship. So these are all not taught regularly. So being in a medical college, very much happy, and also setting up private clinic. So there will be entire autonomy will be there, but that liabilities, staff, managing the staff, problems with the staff, problems with the patient, increasing the market. Okay, so all the everything A to Z you yourself has to maintain. So it will be autonomous. You have autonomy, but at the same time you have the liabilities. Any questions? Feel free to ask. So this should be more of an interactive session. How many are planning to start private practice immediately? Good. Okay. and how many are planning to start a rehab center, which is very much profit generating. That is very much a huge shortage now. Any doubts? You can ask. So, two ways you can take it. So, how you use your social media and all. So, there is also recently we discussed. So, how you get the reviews in the social media and all. So, always better ask review the patient who got satisfied, especially during their second or third visit when their acute psychopathology is subsided and they very much both the patients as well as the family members are satisfied. Okay, so I use that technique. So most of the times I have seen that initially how much we treat, we give also, they are not much satisfied and all. So they try to give 1 or 2 stars, but after some time, so when you ask the second or third follow-up during their remission, they are always ready to give you 4 or 5 stars. Okay, and recently there is a WhatsApp conference, Zoom conference of how to increase digital mouth publicity, and also their discussion is so if the patient is giving a good rating, always give concession in the medicines or concession in the consultation and all. And of course, those who are very good in marketing skills and all, who are ready to make Insta reels and YouTube shorts, that is always it's always good. So we know that the generations they are very likely to come to you seeing Insta reels and all. Okay, I had some patients. How you came is they are telling that I have checked in the ChatGPT who is the better psychiatrist or in the Vijayawada or like that. So even the 15-year-old or 16-year-old, they are ready to use the ChatGPT. Of course, they are not ready to use the psychotropic medication. I feel that the stigma about psychiatry is still in 1980s, even though we are in 2026 using AI, using ChatGPT, Gemini and all. So they always want some reason to, instead of it's the vulnerability and all. Okay. So I also waiting for like other specialties and all to immediately check for like functional MRIs or functional PET scans. So they always want the evidence. Where is the evidence? So I always say that our psychiatry is the only branch which depends entirely through clinical examination. Okay, for diagnosing and treating the patients. So in that way we have to, of course, negative publicity will also be there. How many of you are maintaining 2 numbers, mobile numbers? I always say better maintain 2 numbers, one completely personal and one for either clinic or giving to the patients and all. Because that doesn't cause problem in your, because the patients try to call 1 o'clock, waking up and asking that I am not getting sleep. So we get clearings from our spouses. Other number you can always available through WhatsApp or call forwarding, so where they can call to the clinic receptionist and they can forward the call to you and all, or calling in the WhatsApp number. So there will be their own individual tailored techniques for each of you. So that is what I tell. So each practitioner will have their own unique therapeutic alliance with the patients that will create. So there is no many. Of course, sometimes I think that many people are coming. So where they will have this footfall of patients, but there are X number of patients in the society. If you want to say, many are having compulsive and impulsive traits, who they need psychiatry referral, and also what is needed is your way of communication, how they approach you and all. And some of my colleagues say that so if you are not able to succeed means you are not able to grab the patients which are mostly going to the other specialties, even though they are having the psychiatric problems and all. So there is so much scope. Of course, initially you can restrict your scope of practice only to certain extent, or you can go with psychotherapies if you have free time in later, or if you go further, you can liaise with the RTMS, DTMS and all. Okay. Of course, in the initial days you can practice general medicine also. So many patients, sir, if we always do the investigations, sir, they ask, sir, BP means why I have to go to the other doctor, sir, you only put some medication for the hypertension. So better always have grip on your MBBS knowledge also. That will be helpful for both for your practice as well as recognizing the underlying medical causes. What else? How many of you are having financial backup to start a clinic without any joining in a medical college? So, most of my generation practitioners in Sharad or so many practitioners in Vijayawada, we all started with medical college and then transferred to the private. There are certain models.
How are you going to deal with the transfers from the patients? Because here there is a lot of autonomy, but in medical colleges we can always refer to other professors.
Yeah. So this is the problem I had. So especially with the VIP patients, what you call and all. So they want to talk, they want to consult at any time without any delay, and especially females with, from a very influential background. I had experiences and all. So I always keep a check. Okay. So so that avoid the counter transference and all. Okay. So I am only doctor. Okay, I can help only for medications. And nowadays I am so I am telling I am a psychiatrist and a medicine graduate who treat your problems with medications. If you want other forms of therapy, so definitely there are help from the psychologists and all. Okay, so that way I am avoiding the transference and all. So restricting yourself and immediately recognizing as early as possible, so that it may not increase in severity and all, causing problems and all. So depends how many of you are planning to practice together. Like-minded people. So after completing my SR-ship, I another 2 or 3 doctors we planned, but initial financial and all, so we separated. But each one of us settled at different places. One in US, one in Hyderabad, and one in government setup and all. So maybe in Vijayawada that hasn't started. That can be. So last week the same topic we have discussed in the South Zone Psychiatry Conference. So there the other panelists also came to the conclusion as of now, better always liaise with the other psychiatrists or with the other, at least increase the scope with keeping psychologists or other type of speech therapies and or child psychiatry, or those areas where there is niche, that means especially if you take child psychiatry and all. So child psychiatry has been taken away by the developmental pediatricians and all. So like that, so there is very much scope in that like that. So de-addiction rehab centers and all. So sharing the proprietorship and sharing the liability and all. So because now sole proprietorship with these costs and all, somewhat, of course it will give much autonomy, but at the same time, so you should be almost initially like 16 to 18 hours you should be ready for initial. And we also discussed about how much you will get profitable after your postgraduate. So my own examples. So when I'm studying my post-graduation, my mother asked how much salary will get immediately after. I told her immediately I will get a job nearby medical college and 1 lakh salary is waiting. But for that I have to wait for 3 to 5 years. Okay. So these are all the practical. So even the other panelists are told at least first 3 to 5 years. So in your private practice, it will be somewhat you will be have to wait with patience. And marriage also determines everything. How many of you are planning to do postdoctoral fellowships? DM. Good. So that will also increase your scope and all. And there is only one corporate hospital taking psychiatrist, in-house psychiatrist. All others, they don't want to take psychiatrist in-house. They want psychiatrist to come from outside and see the patient and dispose of. So maybe in Hyderabad change, but they always think of revenue, how much you are going to generate. So they want immediate revenue. So long term, so you know that our pharmacy used to generate the revenue and all, but the corporate wants the immediate revenue and all. So,
Thank you, sir, for that very practical presentation for us. So I request Dr. Sharad, sir, to come and felicitate. I invite Dr. M. Jhansi Rani, Assistant Professor of Psychology, to talk about the current trends in practice of psychotherapy today. We welcome you, ma'am.
Good afternoon. I can hardly see you. Okay. So, practice start చేయడానికి సంపాదన ఎలా చేయాలో చూద్దామా? Seriously, psychiatrists థెరపీలు చేస్తే people are ready to pay a lot. Psychologists కంటే psychiatrists థెరపీలు అంటే వాళ్ళకి నచ్చుతుంది. So we are at the junction today where psychotherapy is at a point where you need to decide between tradition and change. we are witnessing an important shift from standardized approaches to personalized psychotherapies, and from like purely face-to-face sessions to digital and hybrid formats. And then these changes are not just advancements. As clinicians or as therapists, we have to look at our knowledge about therapies from a different point of view. So this is going to be the session's overview. We'll quickly look into the landscape of psychotherapy and then trauma-informed care. Before that, third wave therapies, and then telepsychotherapy. Everything at a glance. Because you're all professionals, you can go deep into the topics later on, but you can have a gist of everything. Okay. These are the numbers. About 970 million people are in need of mental health services. But even in the high economic countries, there is about 45% gap in those who are receiving the services. When it comes to the low economic countries, it is about 80%. And we have almost about 500 types of therapies. That shows how that shows how psychology, how different each one's psychological landscape is. So, despite this, from structured therapies like CBT to more exploratory methods, like clinicians have a wide adaptable toolkits, provided we are getting a proper training or guidance or knowledge about what tools we have. So now it is not the lack of knowledge, again it is lack of access. That is the problem in reaching, we are unable to reach the patients, even though we have so many varieties of therapies and the knowledge about therapies. So even WHO and the National Mental Health Policy, they are all emphasizing on the psychological services, the need of psychological services. And the diversity and the rising global demand, understanding current trends, the psychotherapy is essential, and these trends help improve effective and accessible services to ensure that the cultural relevance and in the mental health care. So given this treatment gap, now the question is how this psychotherapy is evolving to the needs of the modern society. So when we look at the first wave therapies, the focus was majorly on the behavioral aspect of the clients. So we used to, from the behavioral aspect, that is, if a child is scared of dogs, then you are just exposing him gradually, observing only, focusing only on the observable behavior, and then we are just not focusing on the thoughts or feelings or the beliefs. That was about first wave therapies. Coming to the second wave, the focus was shifted to more on cognitions. So the theorists like Aaron Beck and Albert Ellis, the focus was shifted to identifying and restructuring the negative thoughts So that is what we commonly known as CBT now. For instance, if a student is not able to study, is not focusing on academics and more on playing or spending time on gadgets, so the approach of a therapist will be to so in first wave, it is like the approach will be to reward him. But in the second wave, if they have a negative, the focus is on the cognitions. So if they have a negative thought process, for instance, if the student says like, I'm going to fail no matter what, then the therapist's approach would be to give him an understanding about his negative thought patterns, and then to make him understand that he can change his thought process, like if I prepare well, I can do better. From there, the third wave presents a further shift. Instead of trying to change thoughts, it focuses on changing our relationship with them. This approach emphasizes the acceptance, mindfulness values, and broader concept of behavior. Here we are not just addressing the behavior, not just addressing the negative thought patterns, we are also trying to change how we relate ourselves to the inner processes. For example, in chronic depression, rather than changing thoughts like I am worthless, the therapies like acceptance and commitment therapy helps the individual to observe the thoughts without judging and continue to engage in value-driven activities even in the distress. So this evolution highlights a broader focus not just on symptom reduction but on the long-term well-being and the ability to live meaningful life even in the presence of distress. So the third wave therapies include ACT, DBT, MBCT, CFT, and behavioral activation. Let's look at ACT. So among third wave therapies, acceptance and commitment therapy has emerged as one of the most widely used and evidence-based approach. There is a hexaflex. The 6 core processes tell us how the 6 interacting processes tell us about how we can help better function. So the first one is acceptance. So when you take thoughts, feelings without trying to avoid or suppress them. You're not supposed to avoid or suppress your thoughts. And then, for suppose if a person is in pain, he cannot decide this pain to lead his life. Okay, we have pain, but this pain, it doesn't have to stop him from living his life. So that is acceptance. The pain is there, but I don't have to stop my life because of it. Then the cognitive diffusion, learning to observe thoughts as mental events, not as absolute truths. So we tell the patients like we are not our thoughts. Thoughts are like any other, thoughts are like mental events. They are not our definition of the self. So if you get a thought like I'm a failure, according to the cognitive diffusion, it should be like I am having the thought that I am a failure. It's not like I am a failure. That means you are observing yourself. It is not that you are a failure. In instead of I can't do anything with this pain, you can say I am having the thought that I can't do anything. And being in the present moment, that is being aware, consciously contacting with the surroundings, with the here and now, rather than being lost in thoughts about the past or future. So being mindful and engaged with the here and now is about mindfulness. Then self as a context. So this is how we understood about self. So developing a stable sense of self that observes experiences without being defined by them. You are not being defined by your experiences. So you are not your thoughts, feelings or roles. You are the background awareness, the one that is watching your experiences. Instead of saying I am anxious, no, I notice that I am experiencing anxiety. This is what is seeing self as a context. And then the values, identifying what truly matters to the individual. So even though you have pain, what are the values of your life? That is, say the family is important to me. Then from there, the sixth one is taking committed action. So taking consistent behavioral steps guided by the values, even in the presence of distress. So to choose to spend time even with the distress, to spend time with the family. So the key shift in ACT is that the goal is not symptom removal, but improving functioning and quality of life even in the presence of distress. So it's especially useful in chronic and relapse-prone conditions such as substance abuse, etc. Then coming to this acceptance concept, we already practice a lot of acceptance in life, but only for the things that are pleasurable to us. So, but according to ACT, even in the, this acceptance should be goal directed. So for our long-term values such as growth, responsibility and relationships. So that's about ACT. And then dialectical behavior therapy. So it's, as you all may know, it is developed by Marshall Linehan. It is initially used for borderline personality. Later on, it was adapted for adolescents and then bipolar disorder as well. The biosocial theory forms the conceptual backbone of this dialectical behavior therapy. What biosocial theory says is people from invalidating environment and who are emotionally sensitive, that is biologically vulnerable, those develop this emotional dysregulation. So suppose if a child comes home from school feeling sad or feeling hurt because the friend ignored him or her, when he shows this sadness or maybe low mood, if the parent says like, why are you overreacting? That means he is not validated, and sometimes the child may feel that he himself might internalize the feeling that he is overreacting, or maybe he is not managing himself well. So in the invalidating environment, they have this tendency to show more behavioral outbursts just to get the attention, or sometimes they may be withdrawn totally. So the more dialectic response would be a more balanced one, where it is possible to have it two differently. A more balanced response would be like, I can see that you are really hurt because your friend ignored you. That makes sense. That is acceptance. And then let's also think about what you can do next. or how to handle this situation. So this is basically a skill-based approach. The main, they have 4 modules, and the main one is mindfulness, which is a core for all the 4 modules. So it is the core of the DBT, and it means paying attention to the present and non-judgmentally involving ourselves into the current situation. And then wise mind concept, because if you are always on the emotional mode, or if you are always on the logical mode, this is going to put you in troubles. Like you can't regulate your emotions, so you have to use wise mind, which is a balance of both. Then the next one is distress tolerance. Distress tolerance focuses on survival skills. This is like emergency room in psychotherapy. You can use it only for minutes or days, not for continuously. Later on, once you achieve once you are stabilized emotionally, you can go to the other modules like emotional regulation. So distress tolerance, you are trying to be stable in a crisis situation without spoiling the situation more. So to attain that, the goal is to move from a state of crisis back to a state of baseline. So the skills would be, these are certain skills that they have to apply, like TIP and accept, the acronyms. So TIP is basically temperature, intense exercise, paced breathing, progressive muscle relaxation. Basically you are trying to bring back your homeostasis. Then the next one is accept. These are all certain small activities that you can do to achieve the equilibrium back. So activities, contributing something to somebody, give you some feel good factor. And then comparisons, compare the even more worse scenarios that you have come across. Then emotions, so trying to shift the gear. That is, if you are feeling sad, watch something funny or something like that. That is again pushing away, that is boxing up the problem for a while. Just keep it aside for a while. Then thoughts, like counting backward, that means you are occupying yourself into something else which really takes your attention. Then sensations is like holding an ice cube or snapping a rubber band. So these are the techniques to get back to your baseline. The next one is radical acceptance. Radical acceptance is always misunderstood. It is not like accepting whatever is happening, but it is a tool, it is just a functional tool, not a normal, that is not a moral approval. That doesn't mean you have to approve everything. It is like you can accept that it is raining. While hating the rain, you can even hold an umbrella. So that is what is radical acceptance. So while distress tolerance is about surviving the storm, emotional regulation is like knowing the cues, knowing the weather, and building a sturdier house. So first thing, you have to label the emotions. Identify and label your emotions. Most of the times, people who are raised in an invalidating environment will not know how to identify their emotions. For everything, either they are over-explanatory or they are explosive, or they say like we're happy or sad, that's all. So you have to, they say no, you have to name it to tame it. To regulate it, first you should know what it is. So the goal is to move from I am freaking out to I am feeling secondary shame because I felt primary anger. So this is the goal. 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 So this is the So why it works? It is like identifying an emotion actually reduces its intensity. It moves the experience from where? Amygdala. So from the emotional center of the brain to logical center, that is PFC. Then there are please skills. The please skills are like reducing the vulnerability by changing certain lifestyle modification in a continuous basis. Like, physical, checking for the physical illness, eating properly, avoiding substances, balanced sleep, exercise, etc. Then taking an opposite action. It works as the brain behavior loop actually. So how the cycle works is when there is fear, you have an urge to hide, and when you hide, the fear increases. Why? Because your brain says you have avoided the fearful situation or stimulus or whatever. But then how to break the cycle? When there is fear, there is an urge to hide, but instead of hiding, if you are approaching, then your fear will decrease because the brain learns that there is no actual pain, actual fear. Then come to interpersonal effectiveness. Focusing on improving communication and relationships is important. And then there are DMN skills. These are all, if you see any of the DBT manuals, you find all these things clearly explained. DMN skills are like assertiveness skills. So you describe, you express, and you assert. That is like, if you are coming late, then clearly use I statements like, I need you to call me if you are going to be late. And then reinforce, explain the positive effects of getting what you want. If you start on time, we can finish early. So then the give skills is to maintain the relationship, that is being gentle and being interested in the other person, and then validating and maintaining an easy manner. Then the fast is like self-respect effectiveness, that is not being over-explanatory, be fair to yourself and others also, and then no apologies when there is no mistake from your end. Many times they try to people please. Then stick to values. Then be truthful. So setting up boundaries is also an important aspect of assertiveness. So never say, okay, I'll do it, even when you have no time. I understand this is important, but I am not available today. This is how you can assertively convey that. So the DBT skills work together, the mindfulness being the core of it. Then trauma-focused care, it's not a specific therapy modality, but there are some 6 principles given by Substance Abuse and Mental Health Services Administration. This is from US. So the 6 key principles include safety, both emotional and physical safety, and trustworthiness. So clear-cut communication, and explaining about what happens in therapy and what is the processes, etc. Then peer support. So sharing the collective experiences will give you more strength to overcome the issues. Then collaboration and mutuality. It is not hierarchical. The client and the patient both will decide on how the therapy goes, the pace, and what are the actions they are going to take. Then empowerment and choice. Focus on strengths rather than deficits, encouraging autonomy and decision making. And then cultural sensitivity. Many times when the client is from a background where sharing personal experiences is, they'll have their own family practices. So if they're sensitive to share the information, we have to go with the pace of the client, not to push them, and be, acknowledging their problem with expression and take him from there. So this is recommended for PTSD. It's an 8-phase structured protocol. When used with, so we are talking about EMDR here. So when used bilateral stimulation, like using a hand or using a finger or tapping on the legs, you are stimulating the right and left sides of brain and body. So by doing so, we are trying to help the client to process the traumatic information, whatever is there in their mind. We are trying to process it and store it properly, because the memory many times fragmented. It has a level A evidence for PTSD from WHO, NICE and APA. So bilateral stimulation activates the brain's adaptive information processing system. It's like your brain is stuck somewhere, and somewhere in the scary moment, and the BLS helps to unstuck and file it in a proper way. That is how the EMDR helps. So coming to mindfulness-based interventions. So mindfulness is all about, by now you must all be aware that it is from the Indian Buddhism nunchi ochindi kada. So Kabat-Zinn was the first person. This is first used for stress reduction. But the irony is, ikkadi nunchi elli వాళ్ళ దగ్గర ర్యాండమైజ్డ్ స్టడీస్ అన్నీ చేసి స్టాంప్ వేయించుకొని వచ్చాక మనం వాడుతున్నాం అనమాట. So this also has a huge evidence base, and we have a long-standing connection with mindfulness through Buddhist meditation practices, yoga and pranayama. But the important thing is, there are structural changes in the prefrontal cortex and amygdala, which they have documented evidence for. So this is an 8 weeks structured program. Body scan meditation, mindfulness breathing, gentle yoga. So the focus is increasing awareness of stress responses and reducing reactivity. We learn to respond instead of reacting after practicing mindfulness. Then mindfulness-based relapse prevention. Again, mindfulness is the core skill. From there, the key elements would be triggers, cravings, learning to pause instead of reacting for the urges, and then healthier coping responses, responding rather than reacting. And then mindfulness, self-compassion. I think even professionals should have this, because we are always overcritical. So we have to learn to love ourselves first, is what the mindfulness self-compassion says. Even with the friends or any closest person, we don't express certain things that we tell to ourselves many times. So that is what mindfulness self-compassion talks about. Telepsychotherapy and digital mental health. COVID తర్వాత అందరి బిజినెస్లు ఎలా ఉన్నాయో తెలియదు, కానీ సైకాలజిస్ట్ బిజినెస్లు బాగున్నాయి, బికాస్ దే కాంట్ కమ్. రోజు మామూలుగా అందరు తెలుగు వస్తుందండి, అసలు రాని వాళ్ళు ఎవరు ఉన్నారా? సో రోజు మామూలుగా క్లినిక్ వచ్చి కలిసే వాళ్ళు కూడా ఊళ్ళో ఉన్న వాళ్ళు కూడా ఆఫ్టర్ కోవిడ్ దే స్టార్టెడ్ ఆస్కింగ్ ఫర్ ఆన్లైన్ సెషన్స్ బికాస్ they can save the time and money as well for transport. Despite having certain concerns like confidentiality, consent, etc., but this has increased to 30 times in US, but in India it is a lot more than that. And then the challenges are like digital divide, like not everyone has the access to this, and then they don't know how to use the digital devices, many of them. So, and then the usual concern about privacy and confidentiality. So these are some tools that sir was mentioning about the tools. No? So we have self-help apps. These are like you can use it on your own, and few of them are like therapist guided, and few of them are like safety monitoring, that is suicide prevention, crisis navigation, so AI emotional support. చాలా మంది ఇప్పుడు వీటిని ప్రయోగాలు చేస్తున్నారు, మెయిన్లీ అడాలసెంట్స్. సో వాట్ వీ హ్యావ్ టు రిమెంబర్ ఇస్ only 4% out of 10,000 mental health apps have peer reviewed evidences. If you want to suggest to your clients, please be mindful of that. The neuroscience informed psychotherapy. I don't want to enter into your territory, but I had to keep this. Neuroplasticity, you all are aware of this. It refers to the brain's ability to change its structure and function in response to experience. This includes psychotherapy. There are, like I said, there are neuroimaging studies now show therapy produces similar brain changes as pharmacotherapy. When someone engages in therapy like CBT or trauma therapy, they're just not talking, they're carefully rewiring the brain pathways over time. Then polyvagal theory, this talks about how the nervous system shifts between safety, danger and shutdown, and how this affects the emotions, behavior and relationships. Then predictive processing offers a new unifying model for understanding anxiety, depression and psychosis from neuroscience standpoint. So in predictive processing, the brain constantly makes predictions about the world. When the psychological problems occur when these predictions are biased or inaccurate, or fails to update its model of reality. Like anxiety is due to brain's over prediction of threat and danger. Then interpersonal neurobiology, it emphasizes the integration of mind, brain and relationships. So these three constantly influence each other, and in this you have a window of tolerance, that is the optimal phase where we are within that. When we are within that window, we are calm and stable. Above the window, hyperarousal. Below the window, we are hypoarousal. In trauma work, when you are in trauma, this window narrows down, and with therapy, trauma-informed therapies, or with the therapy, we try to be in the window and slowly widen the window. That's about interpersonal neurobiology. Why cultural adaptation matters. So almost all the therapies we have are from West, I feel, except mindfulness. So in the collectivistic society like in India, Western models don't fit usually, but we try to push them, we try to make it work. but the studies say that there is a very good chance of good outcomes if we are making them culturally sensitive. So the change can be with the language, the change can be with how you use the idioms or examples. So if it is grounded in the day-to-day life or the language of the person, that will be more effective. And we have these Yoga Nidra for PTSD, Sudarshana Kriya for depression. These are all having RCT evidences. So the change can be keeping the core scientific principle as the same, but changing the all other modalities that can help the person to understand easily by making cultural changes. NIMHANS has this CBT adaptations for schizophrenia and depression in Indian populations. And nowadays there is growing evidence for yoga-based interventions also, particularly this Sudarshana Kriya yoga. Then group and community-based approaches. So there are these are different types of groups, like skill-based groups that work on a particular skill, then process groups. So they process the emotions or interpersonal relations or self, and then peer support groups, like people having similar experiences will try to help each other, and then community-based. But there are certain principles, factors, why the group therapy is so effective. Anyway, this is more cost effective, but why it is effective means there is an installation of hope, that is, if they are benefiting, I may also. Or then universality, like it might work for everybody. Then imparting information, that is, the information is passed on to the clients, not just from the therapist, from the group members also, because they have similar experiences. And then altruism, when you are helping somebody, that gives a feel-good response. And then corrective recapitulation is, we all have patterns to interact with family members or extended families, or those patterns we tend to re-experience during the group psychotherapy. But then in the group therapy, you are in a safe environment where you are understood non-judgmentally. So you will contemplate on where you are going wrong and try to correct yourself, because the environment is non-judgmental and safe. Then socializing, and then imitative, that is, they try to model the therapist and the group members also. And interpersonal learning, group cohesiveness, catharsis, of course we know, you get people to listen to you. And the existential factors, like understanding life realities and responsibilities. So in Indian setting, group therapy is more helpful to reduce the stigma, because when everybody is in the same pace, you can't feel that stigma about seeing a therapist or a psychiatrist. Integrative and trans-diagnostic approach. So integrative is like you are integrating certain principles from various approaches, and trans-diagnostic is you are addressing the various common factors from various disorders. That is, if you are seeing a patient with anxiety, depression, what are the common factors? So unified protocol is one of the trans-diagnostic approach, which has evidence for OCD, PTSD, RCT, and it has RCT evidence, and it is also equal to single diagnosis protocols when you apply it in a trans-diagnostic approach. Then mentalization based therapy. Mentalization is understanding others' feelings, thoughts and emotions along with oneself. You are not supposed to get confused with theory of mind. This is different from theory of mind. In theory of mind, you will know that they also have a thought, they also can understand. But here you are trying to understand the other person's state of mind, what exactly they are feeling, along with how you are feeling now. So, because of failure in this mentalization, there are many personality issues in people which would lead to psychological problems. So, focusing on this, there is mentalization based therapy, then emotion focused therapy. It combines with Gestalt and attachment theory, focusing on emotional processing as the change mechanism, strong evidence for couples and depression, people with depression. So this involves Gestalt techniques like empty chair technique, etc. And we are reprocessing the emotions. Then narrative exposure therapy, this is mostly useful for Indian setting where there is lot of sensitive places and lot of migration. So integrative testimony therapy. So we are trying to tell the client, narrate the traumatic experiences, and then they have to understand that it is part of life and that it is not currently going on. It is not something that is currently going on, because in trauma that is what the clients experience, as if it is going on now. Psychotherapy for psychosis and severe mental illnesses. CBT for psychosis is majorly focuses on distress tolerance and normalization of the symptoms, unlike cognitive restructuring. And then avatar therapy, digital avatar embodies persecutory voices. So the client will give a face or a picture, and the therapist will use the voices. So here the distress related to the voices will be reduced, because the client can see it as a person than something unknown. Then open dialogue, this is a Finnish model. It is like when there is when the symptoms occur, they will hold a meeting along with the family members and the patient, also the therapist. But this is not yet proved in the other settings other than Finland. Then family interventions. We all know that expressed emotions are the major reason for the relapse in schizophrenia. So by addressing expressed emotions, involving the family members with psychoeducation and behavioral techniques, the family intervention approach is helpful in psychosis. When you look at the lifespan perspective, because the therapy should be like developmentally tailored. For children, it is play therapy, directive and non-directive. Directive is like the child will direct the play, and the non-directive, the therapist will observe and reflect and then supports the child. Then trauma-focused CBT is gold standard for childhood trauma. Then parent-child interaction therapy. Parent-child, this is also more helpful in trauma, where the child gets help through the relationship, developing the relationship with the parent. And then child-parent psychotherapy is for behavioral problems in the child, and parent and child relationship. Then for adolescents, DBT, that is for DBT for adolescents is more helpful for suicidality and non-suicidal self-injurious behavior, and then for BPD traits. Systemic family therapy is a type of therapy that looks at the person's problem in the context of their family and relationships. So, not as an individual, they have to address the whole family and look for the patterns like circular thinking, like parent criticizes, the child withdraws, and then parent criticizes more. So, it helps on focusing more on the patterns among the family members, not just the client himself. Then in geriatric population, life review therapy, which focuses on the pleasant events in life, and the reminiscence therapy is more structured, where this focuses on reminiscence therapy focuses on the pleasant events in the life and recalls the social connections, and not a deep analysis. But life review therapy is more structured, where systematically the client will reflect on the entire life. So the therapist competency, supervision and training. So it is, declarative knowledge is more important. But all said and done, the therapeutic relationship, as Pawan was saying, accounts for 30% of outcomes in psychotherapy. So the first session, how you interacted with the client, will make the most of it. And then reflective practice. So this is like continuous learning. You have to look back on what you did, understand why it happened, and use that insight to do better next time. So you always have to be reflective, otherwise we are blocked. Self-awareness and openness to feedback, willingness to question your assumptions, and continuously thinking about and improving how you work is just what you do in the reflective practice. Ethical and legal framework, you are all aware of this, but then just to mention, informed consent, even in the digital platforms you have to take it, confidentiality and its limit, and competence. Only apply the therapy that you are well aware of. Just not use anything that is fancy. And someone was talking about transference issues. So avoid social, financial, or if you remember a few months ago, we had this case, one therapist committed suicide because she married to a client. Here you see all these boundaries are crossed because it could be her personality. That is where again the thing about reference. If this particular case is not yours, you always better to refer this to somebody. Suppose if you can't handle antisocial personalities, refer it to somebody. You cannot handle. Again, crossing the personal boundaries, and the most important thing is self-disclosure. Self-disclosure should happen only when it is really adding on to the therapy, really adding on to the client's benefit. And that too, it should not be forced. Like many patients will be asking all the personal questions. So you have to be aware of such things. Cultural and religious sensitivity. If someone says that I did this puja so I got better, we are not supposed to attack them, saying no. AI and precision medicine and future of psychotherapy. Precision psychotherapy, is matching the therapy. Like suppose if you have a patient with superego dominated personality, which therapy you will choose. Like similarly to prescribe a medicine, you will see all the biomarkers and their premorbid medical conditions. So similarly you have to look for the factors of the client, other psychosocial factors of the client to choose the therapy. And then AI can do the session transcription, sentiment analysis, dropout predictions, but cannot replace the therapist. And then virtual reality, it is having a very good evidence base for PTSD. So person will wear that, what is that? And they'll give the environment, like whatever he is scared of, and the therapist will be guiding them. And it seems it has a good research base. So మనం ఫోబియా పేషెంట్లు అందరికీ అది అప్లై చేసేయచ్చు. అది పెట్టేసి విల్ గైడ్ దెమ్ టు జంప్ ఇన్ టు ద వాట్ ఎవర్. And psychedelic assisted therapy. So the therapy combines with powerful altered states and structured psychotherapy. Shows strong promise for depression and PTSD, but it is very controversial. But there is a high impact, and the responsibility and risks are also more. It seems in Australia certain drugs are allowed with some conditions. So the stepped care model is really beneficial for a place like India, because initially we'll go with the self-management like lifestyle modifications or psychoeducation by the ASHA workers, etc. And then low intensity psychoeducation, ICBT, guided self-help. Then this model is only when the lower level is not helping or good enough for the client, they'll go to the next level. So this is suitable for us because of lack of sufficient trained persons or lack of reach or whatever it is. So ultimately the future of psychotherapy lies in integrating the human empathy with technological precision, ensuring that care remains both scientifically effective and deeply personal. Thank you.